So can we go ahead, ma'am? Sir, I join. Okay. Madam,
Yeah, now today, who is Sarita is there. Dr. Sadhna will have to take over and start, no?
Yeah.
Dr. Sadhna?
Phone. I'm here.
You are there. Okay, good. Chalo, Dr. Sadhna is here then. Let her give her address, then I will talk.
Okay, fine. Just so a warm welcome to yet another ICOG certified course that is based on infertility, and the leadership of Dr. Sheila Mane, who is our never tiring, never fatiguing, our chairperson, Dr. Ashok, myself, Pratik, Sarita, and Swarna. We, on behalf of everybody, I welcome all the delegates and all the faculties of this ICOG certification program on infertility. So we have a huge number of registration, and that actually shows that infertility is today a very, very important subspecialty as well as the part of routine OB-GYN care. The important thing is that infertility is a science, infertility is a big industry, and the new generation has a different approach towards infertility management, and the senior people and the mid-level people have a different perception of infertility. Our conveners are Dr. Pratik Tambe and Dr. Sarita Bhalirao, and day one convener was Dr. Seema Pandey Jairani, and today convener are Dr. Facey Lewis and the Monica Singh. Yesterday we had a wonderful program on the basics of infertility, and I think that everyone have been benefited by logging on this program. And today we are focusing on the male infertility. So male infertility is something which is actually, we can say, it is still a secret to science and to nature. It is a lot of issues which are unsaid. It is ego issues, it is family issues, it is social issues. And as a obstetrician and gynecologist, and as a infertility expert or the IVF expert, actually we need to understand everything, something in science and many things beyond science. I fully believe that today's program, which has been so well conceived by our today's convener, right from semen analysis to the surgical, like a sperm retrieval technique, and the panel discussion, we have a wonderful, very, very expert ART specialist. We have embryologists, we have the leaders, as well as we have amalgamation of the young people. We wish you a very happy learning, and we wish that as a obstetrician and gynecologist and as an ART specialist, this is one of the most challenging aspect of our fraternity. And by learning from the expert from the Pan India, all of you will understand that what should be done when the patience is needed, when perseverance is needed, when right time intervention is needed, when technology is not to be used very aggressively, and when technology is to be used really aggressively. So we wish you all the very happy learning, and we hope all the best to our all ICOG people who have joined, and we hope that it will really matters, and the changes we will see slowly in our real day-to-day clinical practice. Thank you very much.
Pratik, are you there?
Yes, ma'am. I'm logged in from my phone. So welcome everybody to the day 2 proceedings. Thank you very much for joining us in huge numbers yesterday. I would request our chairperson, Dr. Sheila Mane, to give us a few words of encouragement. Dr. Ashok Kumar will join in later since he's busy right now. We'll have Dr. Sheila Mane's address.
Yeah, thank you. Thank you, Pratik. I think all of us, we know that yesterday's program was a real jam-packed virtual halls. We had around 1,000 people, and same, I think, will be the response today. And as Dr. Sadhna has already told about the importance of today's program, and also why it is important for the OBGYNs to have this infertility certificate course. And I think this is a real knowledge cafe, I must say, that virtually everybody is getting it sitting in your own place. So welcome you all once again, and thank you all for joining in big numbers. And congratulations once again, Dr. Pratik and Dr. Sarita, for conceptualizing such a wonderful program. Over to you.
Thank you, ma'am, for your words of blessings and encouragement. I will hand over to today's conveners, Dr. FOGSI Louis, who is the past Vice President of FOGSI, and he is now the Treasurer of ISAR as well, and Dr. Monica Singh, a well-known fertility specialist from Bhopal. Over to the two of you to conduct the further proceedings. Monica, you can take it ahead.
FOGSI sir, please unmute. Yeah.
Okay. First of all, let me congratulate for this wonderful initiative. Even though it has been happening, it is being taken in a big way by the present ICOG team. I think we have to congratulate Sheila Mane Madam, Ashok Kumar Sir, Sadhana Madam, and Pradeep Tambe for this for taking this into well structured and in a bigger way. And with this, without wasting time, we have to go for today's proceedings. So, so today, I think Dr. Monica.
Yes, sir. Sir, thank you very much for the inaugural address by our respected Sheila Mane ma'am and Dr. Sadhana Gupta ma'am. Thank you to ICOG for giving me this opportunity to be the coordinator for today, day 2 of ICOG certificate course of infertility. Today, we are having 3 sessions. First session has got 3 talks. Second session has got 4 talks, followed by the last session, which is a panel discussion. So I request the chairpersons of the first session to kindly grace the session 1. Chairpersons for session 1 are Dr. Uday Thanewala, Dr. Rajat Mohanty, Dr. Padma Rekha Jirge, and Dr. Narahari Agasti.
And before going that, I remind you all the participants have to attend the post test, which will be time specific. So yesterday and all, some people were in between. If we are not into that, hearing the talks, and you have to do the post test, that is compulsory. So you have to stick to that. Over to you, Monica.
Yes, thank you, sir, for reminding about that. The post-test is absolutely compulsory for the certification, and each post-test consists of questions derived from the talks itself. So it's going to be very beneficial if you attend the complete program and then attempt the test. I welcome Dr. Uday Thanewala as chairperson for today. He is a senior gynecologist and obstetrician at Navi Mumbai, and also the past chairperson of ICOG. Welcome, sir. I next welcome Dr. Rajat Mohanty amongst us. Sir is Vice President FOGSI 2019 and is the past chairperson of the Midlife Management Committee of FOGSI, Governing Council member ICOG. Welcome, sir. Now I would like to welcome Dr. Padma Rekha Jirge, Madam. Madam is a clinical research fellow in ART from University of Glasgow and the founder director of Prismatic Research Foundation and a well-known researcher and academician amongst us. Welcome, ma'am. Next, I would like to invite amongst us Dr. Narahari Agasti. Sir is Professor OBGY and Advanced Endoscopic Surgeon, Reproductive Medicine Specialist from Odisha, a known academician. Welcome, sir. And I hand over the session to the chairpersons to introduce the first speaker, Dr. Sanjay Makwana from Jodhpur.
Thank you very much. And it's such a pleasure to be on this platform of ICOG. And it's so nice to see that all consecutive chairpersons are doing such a wonderful job of disseminating practical knowledge, which is needed by all the practitioners. And Indian College is doing a great job. Congratulations to all
Thank
those
you.
who are
Thank you,
involved.
Uday. Nice to see you.
So with that, it is... what do? I practice infertility. I practice OBGYN. And when I get a report, when I get an infertility couple, many a times we see that the husband's semen is not done at all, and then you say, no, he doesn't come. He doesn't want to do it. So all these excuses come. And then when you get a semen report, what all actually are you supposed to see? Basically, most of us end up seeing just the count and the motility. Is there anything beyond that which we should be seeing? What is the information which a semen report can actually give you? So that is for that I invite my great good friend Sanjay Makwana from Jodhpur from Vasundhara IVF to please deliberate on this. Welcome, Sanjay.
Thank you, Dr. Uday, and thanks to the team ICOG for conceiving such a beautiful program. And I hope everybody is going to enjoy this. I'll be talking, of course, as Dr. Uday Thanawal has said, about the very important aspect of the infertility, that is the examination or interpretation of the semen examination report. It is very, very important. Basically, it is a primary diagnostic tool to understand about the male genital tract as well as the semen, which is the important aspect of the fertility. So semen analysis basically is the key step in evaluation of the fertility potential of a male partner of a couple. And the WHO has done a remarkable job by bringing out the manual to establish the standard practice for the examination of the human semen. And the manual came in 2021 with the new reference values. But we have to understand at the same time, the majority of the fertile male is expected to have their parameters within the range of 50th percentile. But the fertility is a couple concept. Reference values apply only if the standard procedures are followed in the examination of the semen. One must also understand here, there is a significant overlap exists between the fertile and the infertile semen results. These are the reference values given by the WHO in 2021. This chart is describing all those reference values which are quoted for the semen examination. The examination report must have these report with the clear mention that accepted limit is the 5th percentile. Though the pregnancies can be achieved without any evaluation other than the simple semen examination, but this test alone is insufficient to adequately evaluate the male patient. So how to start? The semen examination can be categorized into the two basic groups. One is the macroscopic examination, another is the microscopic examination. But one must understand the report coming from the lab should have the external quality checks, as the WHO is very categorically mentioned in the manual. Unless you have the external examination or external check for the quality, the report cannot be believed a lot. So let's start it. The interpretation and the repetition of the analysis, when and how is to be done. We must understand before starting or interpreting the report, there is a pre-analytical factors, and that includes the abstinence time. Inappropriate abstinence time can also lead to the error in the report. Sample collection completeness is very, very important, especially the container and the complete examination, the complete sample collection. These are the two important aspects. And third is the transport of the collected sample. If it is not given in the same campus, then it should be mentioned very well that the room temperature is maintained and within 30 to 45 minutes, the sample is brought to the lab. There is a biological variability also attached to the analysis, and that is one must know that the spermatogenesis lasts about 72 days and the repeat testing should be considered after this cycle. If the report is normal, that is known as the normozoospermia, the second test is usually not required. But if the parameters are altered, especially when we are taking care of the pre-analytic factor or biological variability or even the analytical errors because of the very casual attitude of a lab part or a systematic error in the laboratory for examination of the semen, then a repeat is required and should be done after a standard time. So what are the chemical and the physical parameters we must look for when we are looking for the macroscopic part? The fluidification, viscosity, appearance, order, volume, and the pH are the important parameters one must look for. Let's come to the first, the liquefaction process. It takes around 15 to 30 minutes, regulated by the proteolytic enzymes, prostatic secretions, and enzymes such as the prostatic specific antigen. PSA alteration may be congenital or acquired, especially when there is accessory gland infections like the prostatitis, then the liquefaction process may be altered. When it comes to the viscosity, it indicates the ejaculate stiffness. Generally, the stiffness is a homogeneous process and can be increased or decreased due to the various conditions. A normal liquefied semen is opalescent with a cream or gray color. A transparency may indicate the low sperm count, and high viscosity may suggest the prostatitis. If the semen sample is red-brown, then it may indicate the inflammation or infection in a younger man, or when we are looking towards the senior male, then serious pathological conditions like the prostatic cancer may be considered. Let's come to the seminal volume, which is very important. It reflects the glandular secretions. We all know that the majority of the secretion comes from the accessory glands, as high as 90%, and it also has a response to the nerve stimulation during the arousal. So reduced volume may indicate the androgen deficiency or incomplete collections, whereas the pH, which is determined by the acidic prostatic secretions or by the alkaline seminal vesicle secretions. Basically, the semen pH is neutral, that is 7.2 to 7.4. The pH change may indicate a pathological condition or analytical biases. Analytical biases are mainly because of either the examination is taken after a long time, this is delayed in analysis, or there's a more time, the sample is reached to the lab and then analysis has been done. So there's a longer time after the ejaculation that may lead to the elevated pH. So these are the macroscopic variation one can see, like in the pH, if the prostatitis or delayed in the analysis, then you can have the alkaline or the higher pH values, whereas agenesis, seminal vesicle, or obstruction can lead to the acidic or the lower values. Same for the volume. Excess of the volume can be seen while there is an inflammation of the accessory glands, or where the low volume can be seen with the distal obstruction or the partial retrograde ejaculation, androgen deficiency, or incomplete collection. Viscosity is same in case of agiospermia or cryptozoospermia. Viscosity is low, whereas the accessory gland dysfunction or infection or inflammation may lead to the higher viscosity. Let's come to the microscopic interpretation of the semen examination. What are the factors we are looking for? Basically, we are looking for the agglutination, aggregation, sperm concentrations, motility, vitality, morphology, and the presence or absence of the round cells. Let's come to agglutination and the aggregation. Basically, the aggregation is the adherence of both the motile and immotile spermatozoa to the mucous strands or the non-sperm cells. Whereas agglutination is basically the clumping due to the antibodies or infection. Agglutination is more or less seen when there is immunological factors or because of the infection in the accessory glands. But many times, agglutination may be associated with anti-sperm antibodies. And when we are looking for the anti-sperm antibodies, the first sign can be agglutination, though it's not always that agglutination and the anti-sperm antibodies are present together. But presence of anti-sperm antibodies itself indicate either there is a disturbance in the testes and the blood barrier, and maybe because of torsion, trauma, or the testicular orchitis, that may lead to the change in the barrier, and that may lead to the agglutination as well as the presence of the anti-sperm antibodies. Coming to the sperm number, motility, vitality, and the morphology, we must understand the sperm numbers are basically, we can say, is the qualitative assessment of the semen, whereas the qualitative assessments come through the vitality, morphology, and the motility of the sperms. The sperm concentration is defined as the number of spermatozoa per unit volume of the semen. And we all know that semen volume mainly originates from the accessory sex glands. Hence, the sperm concentration is influenced by their activity and does not represent a direct measure of testicular sperm output. And therefore, there is much better reflection of the capacity of testes to produce the sperm referred to the total sperm counts. But there are three common variables we come across about the numbers. One is the agiospermia, there is the absence of spermatozoa in the ejaculate even after the pellet centrifugation. Second is the cryptozoospermia, there is the absence of spermatozoa in the ejaculate but present in the pellet after the centrifugation. With the oligozoospermia, the sperm concentration or the total sperm count is lower than the 5th percentile value, that is less than 39 million of spermatozoa, then we say it is a oligozoospermia. Coming to the sperm motility, the sperm motility is basically classified on the direction and the velocity of the sperm movement into the following categories. It can be progressive, rapid or the slow, maybe non-progressive sperm movements, or there is a immotile spermatozoa. Asthenozoospermia is the term coined for it if the total motility is less than 42% and the progressive motility is less than 30%. In case of the severe asthenozoospermia, one must consider is the congenital cause of the reduce sperm motility, and maybe mainly the rare cause that is known as the primary ciliary dyskinesia. In case of percentage of motile sperm is higher than the 40%, then the vitality test is indicated in order to distinguish between the vital and the dead cells. The extreme reduction in the sperm vitality is also known as the necrosospermia. Coming to the one of the most controversial or the confusing term, that is the assessment of the sperm morphology. The sperm morphology assessment is aimed at the evaluation of the shape of the spermatozoa. As we all are aware, the sperm is made of the head and the tail, which is attached by a midpiece, which is a thicker part of the sperm body. The evaluation of the sperm morphology is the most challenging part of the semen examination, since its standardization is more complex than the measurement of any other parameter of the semen. Human ejaculate contains the spermatozoa with a wide range of the different morphological appearances. In a large majority of the patients affected by the teratozospermia, where the normal forms are less than 4%, head, midpiece, tail, cytoplasmic residue defects, all are seen and combined, and there is a different spermatozoa may present with a different type of abnormalities. This mixed morphological defects are usually related to the defective spermatogenesis or epididymal inflammation. The presence of excessive cytoplasma around the midpiece is also associated with the increased production of ROS and oxidative stress. This is a common nomenclature we come across when looking for the pathological semen quality as per the WHO manual. Most of the terms are well acquainted to us, like asthenospermia when the motility is less than 32%. When it's azoospermia, already we talked, there is no sperm available. Cryptospermia, when the spermatozoa is seen only after the examination of the pellet. Leucospermia is presence of more than 1 million white blood cells in the ejaculate. Same with the necrosospermia, then complete, all sperms are dead in the fresh semen sample. Or normozoospermia means all parameters are within the accepted reference limit of the WHO. How to interpret the three principal sperm parameters? The three principal parameters are the motility, counts, and the morphology. Here, the one example I just quote. In the semen presenting all three parameters corresponding to the WHO lowest reference value, that is the 5 percentile, there are 11.7 million of the progressive motile sperms, 1.56 million of the morphologically normal spermatozoa, whereas a moderately oligospermic male, for instance, has a 25 million spermatozoa, showing 50% of progressive motile sperms and 7% of typically morphology would have a higher number of total progressive, that is 12.5 million spermatozoa, and the normal morphologically normal spermatozoa 1.75 million. In his ejaculate, in respect to a male defined as a normozoospermic, based on the 5th percentile of each of these three parameters. Therefore, the clinical consequence of isolated oligozoospermia in this male remains questionable. The similar scenario can occur when the sperm number is very high, whereas the motility and morphology is slightly below the 5th percentile. Therefore, it's important to interpret all three parameters together rather than seeing the motility, morphology, count individually. It is better always to see them in a totality. Well, all three parameters are lower than the defined threshold, that is the oligoteratospermia, the odd of subfertility sharply increases. The total motile sperm count is a better, basically, the assessment tool, which correlates better with the spontaneous pregnancy than the individual parameters. Then comes another important aspect of the examination of the semen, that is the azoospermia. Azoospermia affects about 8% of general male population. It is incompatible with a natural pregnancy. The diagnosis must be confirmed by the centrifugation of the semen specimen for 15 minutes at the room temperature with a high power microscopic examination of a pellet and with the centrifugation speed of more than 3,000 rounds per minute. The semen analysis should be performed according to WHO 2021 guideline, and at least the 2 semen samples should be obtained for more than 2 weeks apart. Azoospermia can be divided into the 2 parts, the obstructive and the non-obstructive. In case of obstructive azoospermia, the spermatogenesis is unaffected and the absence of spermatozoa in the ejaculate is due to basically the bilateral distal or the proximal obstruction of the urogenital tract. Where in case of non-obstructive azoospermia, the symptoms that can be associated with the 3 different testis histology, that is the Sertoli cell only syndrome, maturation arrest at the different stage of the germ cell maturation, or hypospermatogenesis. The differential diagnosis is a fundamental as the patient management and the treatment options are different. The definition of the etiology is also relevant. Since the non-obstructive azoospermia due to primary spermatogenesis factor cannot be treated with a treatment, and gonadotropin is effective in almost 90% of the cases. In large majority of the obstructive azoospermic cases and the primary testicular failure, TSA-ICSI is the most viable treatment option. In the semen interpretation, the fructose matters a lot when we are talking about the azoospermia, and it must be seen that the report must contain word about the fructose. It is a critical, non-invasive biochemical marker used to determine the exact cause of the azoospermia by assessing the patency of the ejaculatory duct and the functionality of the seminal vesicle. Commonly, the fructose is negative in case of vas aplysia, that is the absence of the both vas or ejaculatory duct obstruction. You can see here in this that the circle is made around the seminal vesicle and the ejaculatory duct, where the obstruction will give the fructose negative, whereas the fructose is positive in the primary testicular failure or obstruction is mainly at the either at the vasoepididymal junction or in the case of proximal part of the vas. The routine semen examination is valuable diagnostic test, though it has its own limitations. In fact, because the infertility involves a male and female factor, it will not be possible to predict the fertility using the parameter from the either partner alone, unless there is a azoospermia in the man or a premature ovarian failure in the women. The azoospermic undoubtedly causes the infertility. The presence of three or triple defect, that is the reduced sperm number, motility, and the morphology, also increases the likelihood of male factor responsible for the couple's infertility. The clinician should also be aware of the fact that the semen parameters are susceptible to variation due to pre-analytical, analytical factors together with the intra-individual biological variability. Therefore, when semen alterations are observed, a second evaluation is mandatory. In conclusion, though the routine semen analysis is considered a poor indicator of the reproductive outcome, it remains a valuable diagnostic test in the couple's infertility. It provides information on whether the infertility can be related to the male partner or is able to identify the alteration which can guide clinician toward the tailored diagnostic examinations and the treatment. Thank you.
Thank you very much, sir, for the lucid presentation. And since our next speaker is Dr. FOGSI Lewis, who is the coordinator for today, I would request our chairpersons to do the honors and introduce Dr. FOGSI Lewis, who will be deliberating on approach to azoospermia and oats. Welcome, sir.
Good afternoon, everybody. This webinar on FOGSI ICOG online certificate course on infertility. I think it will
that's all, sir. Sir, that's all. We don't waste time, sir.
Yes, the C is good. Friend of mine, participated of FOGSI. Please proceed. Today, your talk is an approach to azoospermia and OAD.
Okay, sir.
So please go ahead.
Thank you, chairpersons. I think my topic today is how to approach azoospermia and oligosteroteratospemia. As you all know, I think 15% of couples suffer wait a minute. A male factor is responsible for nearly 30 to 50% different studies. Can I just minimize it? Something is happening.
It's clear. We can see it properly. If FOGSI, just go ahead.
Okay.
We can see it fine. Yeah.
Okay. So this is how the different incidents. I'm not going to those details. But before going into anything to know about the male infertility, we must know about the HPG axis. Just like HPO axis in the females, you must know about the HPG axis. That means in which the hypothalamus controls the pituitary, and pituitary controls the production of the FSH and LH hormone. And FSH hormone is responsible for the Sertoli cell and the sperm production, and LH is responsible for the testosterone production. And And if you look that, sorry, okay, this was coming in between. Okay, this is how it will be. So that the basic FSH controls this test sperm production, and also the LH produces the Leydig cell to produce the testosterone. And we must always know about this negative feedback effect. This controls the production of the FSH and LH, just like in the female's HPO axis. And if you look at the sperm production, it is produced from the testis, and as the previous speaker was telling, it goes into the epididymis, and it goes through the to the vas deferens, and it joins the ejaculatory duct, and sperm is produced during the ejaculation. So now we have seen about the semen analysis, when the patient comes with the report of either oligoacidoteratospermia or azoospermia. First of all, we have to look into detail about the history, what is the duration of the infertility, is there any developmental history, is there any medical or surgical significant history in the patient, what is the sexual history of the patient, any family history, and also then comes the physical examination, and with that we have to interpret the semen analysis. And endocrine test is indicated only in few patients. I will come to that. Genetic test and other things I will come in subsequently. And previously, when we were the MBBS, postgraduate students, a lot has been told about the anti-sperm antibodies, but now because of advent of the ART procedures, not much significance, as it is not routinely done as a part of investigation of infertility anti-sperm antibodies. So coming to the different nomenclature, first we will deal with the azoospermia, where there is no sperm in the ejaculate. So when the report as azoospermia comes, we must repeat the semen analysis after 4 weeks, and then confirm the diagnosis. We must rule out any history of recent febrile illnesses for the male, and exclude any ejaculated problems for that, whether previous ejaculated problem is there, whether there was any retrograde ejaculation was there. So that we have to see that whether the patient had orgasm, and then it is coming. All those things has to be detailed evaluation must be there when the patient first come. So it can be either due to no sperms produced by the testis, quality of not enough to be present in the ejaculate, or it can be due to the obstructive azoospermia. So the differential diagnosis, as I told, must be importance. Retrograde or an ejaculation also has to be clearly differentiated by the detailed history. So after history, we had to go for the clinical examination, and then the hormonal evaluation. So the childhood history, most important is that whether there was any history of undescended testis, bilateral or unilateral, or there was any torsion history, mumps or caries was there, whether there was any associated hernial surgery, when was the onset, when was the secondary onset of sexual features in that individual. So coming to the clinical examination, we have to see the testis, how the consistency, whether it is small, whether the consistency is normal or is it soft. Then you have to see the epididymis, whether it is distended, and we have to also see the vas, whether it is absent or thick or bearded. So this picture tells that to how we have to see. This is a must if you are practicing infertility. Basically, the male examination must be part of your routine. We have this postgraduate to MCH course. We teach all the postgraduates, irrespective of whether he is male or female, by the clinical examination of the male partner is compulsory, and it gives a lot of information. Otherwise, we will be going in wrong direction most of the times. Also, we must look into the other, whether associated phimosis is there, paraphimosis is there, hypospadiasis is there, and presence or absence of varicocele, hydrocele, or hernia in the patient. Even though varicocele per se alone will not cause azoospermia, but there are few studies telling there are very few cases with severe grade for varicocele producing the azoospermia. So that's why we have to clinically examine the patient. Next, we have to interpret by looking into the semen volume. What was the volume? Whether it is volume is very low volume or normal volume, and pH is acidic or alkaline, fructose is present or absent. Just now we heard how this Dr. Sanjay was telling about the fructose association. And coming to the per se the hormonal evaluation, one hormonal evaluation which is most important is the FSH. And FSH, if it is more than 8, especially if it is more than 10, it denotes non-obstructive azoospermia, and if it is less than 2, it denotes a hypogonadotropic hypogonadism in that patient. And protocol for evaluation is that, as I told, the testicular size, if it is atrophied, we have to be suspecting more of an testicular failure, and normal sized or low volume, it can be any of the condition. So if atrophied testis is with FSH is very high, that indicate the testicular failure, and biopsy shows usually atrophy. And if FSH is very high and the testicular size is atrophied, donor insemination or adoption is usually the treatment. And there are anecdotal reports of people are trying in small testis going for an micro TSA, but if it is atrophic testis with very high FSH, usually the chance of retrieval is less. I'll come to that. So FSH, as I told, if it is more than, some studies tell us 7, but mostly is tell it as more than 8 as a non-obstructive azoospermia. But hypogonadism has to be differentiated, especially if the FSH is less than 2. I just put one slide 3 because some studies tell it's 3, but mostly if it is less than 2. In those patients, if the testis size may be normal or low, it can be. And even though it is rare, it can occur. So we have to differentiate those patients, and it is the only main condition where the medical treatment will be effective. So coming to the obstructive azoospermia, we have to see where the obstruction, whether it is absence of vas or where the actual obstruction in the obstructive azoospermia. So in obstructive azoospermia, usually the volume of ejaculate is low, less than 1 ml, and fructose may be absent, as we discussed earlier. Or in normal volume also can be there where the fructose may be present, depending on the site of obstruction. So vasculoplasia usually in present as vas cannot be palpable, and if the ejaculated duct obstruction, usually the vas may be present. And as I told, usually the FSH will be normal, and epididymis will be distended in most of the cases, because sometimes lesion of obstruction can be read testis. So, what is the indication to do the testicular biopsy, especially if it is obstructive azoospermia? Previously, people were doing testicular biopsy, but in obstructive azoospermia, the primary goal must be to know whether there is sperm, especially if it can retrieve from the epididymis or from the testis. Then patient must be counseled that the only treatment which can be done is go for an ICSI treatment, and there must be facility to cryopreserve the sperm, because once you get the sperm, there is a very small chance of developing anti-sperm antibodies, and the second biopsy may not get the sperm. And non-obstructive azoospermia, the results can be testicular atrophy, maturation erect, or Sertoli only syndrome, or hyperspermatogenesis. That is for academic person we have put. And treatment option in azoospermia, as I told, in hypogonadotropic hypogonadism, we can go for medical management. Otherwise, we have to get for surgical retrieval of the sperm. And when we get the surgical retrieval of the sperm, the patient must be counseled. They can go for an ART ICSI treatment for this patient. So first we have to see where we can retrieve the sperm, whether we can retrieve from the epididymis or from the testis. So how can we retrieve the sperm? It is I will come to that. So usually we have to identify what is the site, and first we have to go for a PSA, epididymal sperm aspiration. Then we have to go for the testicular sperm aspiration. So in non-obstructive azoospermia, usually the testis is small, FSH is usually high, and those the chance the biopsy report will be, as I told, either of the four, and the chance of retrieval sperm is less in the normal retrieval. And if we can retrieve the sperm, we can go for an ICSI intracytoplasmic sperm insemination. So how do you retrieve the sperm? It is epididymis retrieval of the sperm is a simple procedure done under local sedation or regional block. Usually, we can retrieve the sperms by a 19 gauge needle with a 10 ml syringe for suction. It is usually an OP procedure. It is inexpensive and effective. It is usually a blind procedure, but usually in obstructive azoospermia, we can get good sperm from the from epididymis. But we must be careful that even this procedure, the patient can go for a scrotal hematoma as complication. So most of the times in obstructive sperm, we can get the sperm from epididymis, and usually that sperm will be mature enough to go for an ICSI procedure. So if we cannot get the sperm from there, we can go for an TISA, that is testicular sperm aspiration. It also can be done with sedation and regional block, and using 18G scalp vein, using 10 ml, 20 ml syringe using negative pressure, we can go for it. And if we it also is in a procedure where no incision is there. It is a microsurgical procedure where it can be done as OP procedure. And in non-obstructive azoospermia, usually the FSH will be increased, and usually you may not get the sperm with a routine testicular sperm aspiration. You have to go for a TISA, that is known as usually the micro TISA. It is best done under microscope, where the testicular tissue is opened and seminiferous tubules are identified, and from the healthier tissue we can identify the sperm, and if we get the sperm, we can use for the ICSI procedure. So the basic goal of sperm retrieval in testicular failure is obtain the sperm with minimal damage and immediate use for the ICSI procedure. And if we get sufficient number of sperms like from the epididymis, testis, you may not get always sufficient number. We can cryopreserve that, and the future retrieval, always if you get the good sperm, that may be the best fresh sperm is best to do for the or get better embryos and better result. And testicular function will be compromised in some case of microtisa, because we are opening the testis. So otherwise, testicular microtisa usually is done along with that ovum pickup or one day before that, so that the second microtisa cannot be done like routine testicular trial tisa we cannot do with the microtisa procedure. So if you get the sperm by these procedures, we have to use for the ICSI. That is, we aspirate one sperm after immobilizing the tail into the cytoplasm of the denuded egg. That is known as intracytoplasmic sperm insemination. So coming to the genetic studies, if there is a severe oligosteroidectodermia and azoospermia, always rule out any karyotyping or Y deletion problem, because this karyotyping can inherit into subsequent offspring. Also, if there is Y deletion, also if the subsequent offspring is a male, this Y chromosome will be inherited. More than that, the microdeletion of the Y chromosome, if it is A, that is prognostic. If it is SDF-A, there is a very almost nil chance of retrieving the sperm. And if it is SDF-C, there is mild to moderate oligosteroidectodermia. I mean, oligo to ceratosely cell according to biopsy. So there is more chance of retrieving the sperm. So not only the chance of inheritance, chance of retrieving the sperm is depending, it can be prognosticated by doing the Y chromosome microdeletion. So that is the importance of doing the genetic test. And regarding the other associated with the congenital bilateral absence of vas difference is the CFT, that's a cystic fibrosis trans receptor gene mutation. So if it is congenital bilateral absence of vas difference, usually if the patient is willing, we have to do for a CFT or gene mutation to know whether that can be, especially if it is the wife is also carrier, that is high chance of getting that CFTR gene can be migrated into the subsequent offspring. So if it is a male, if it is a abnormal semen analysis, azoospermia, you have to do the FSH at least and go for a chance of retrieval of the sperm and go for an ICSI procedure. Coming to the oligoasteroteratospermia, so that is if the defect in concentration, motility, and morphology of the sperm is the oligoasteroteratospermia. So there are different ways of classification upon the severity of the oligospermia, but there is no consensus from them. But if it is less than 1 million, it is severe. And here also we have to rule out the in the history, alcohol, smoking, all those things has to be ruled out. And the most common reason of severe oligoasteroteratospermia is varicocele. One study is telling about 75%, other is 35%. But I just put it both the studies to show that the importance of varicocele, if there is, and also along that we have to rule out other medical and surgical history, as I told in the beginning. And other associated phimosis, paraphimosis, hypospadiasis has to be seen, and detailed male examination has to be done. And also we have to do the endocrine evaluation if the sperm parameters is less than 10 million, and also if there is associated erectile dysfunction,
Sorry to interrupt you,
hypospermatism.
sir. Your time is up.
2 minutes. And also here also the sperm, if the FSH and LH, if it is less, it is hypogonadotropic, and if it is high, it is indicate that patient is going for a testicular failure. We must counsel the patient to go for ART at the earliest. And here that is the importance of the same hormonal patterns as azoospermia. And if the high FSH, definitely we have to counsel the patient. Patient can go for an very bad semen azoospermia in future. So we have to go for assisted reproductive technique. In hypogonadotropic hypogonadism, it is usually first we have to give HCG injection twice weekly for 2 months, so that the testicular Leydig cells are stimulated to produce testosterone. When it is testosterone primed Leydig cell, then afterwards we have to give HMG also. Detail Monica will tell in the medical management of the male factor infertility. Pulsatile GnRH is not available nowadays. So coming to the examination of the varicocele, most important is the clinical examination. If you cannot do, then only go for an ultrasound Doppler evaluation to rule out the varicocele. And if it is varicocele, we have to advise for a subinguinal microscopic surgery. That is the thing which giving the maximum result. And if there is oxidative stress is high, if there is infection in the semen analysis, you have to treat with antibiotics. You have to treat the pyospermia, especially if the WBC is more than 1 million. And if needed, you have to go for a semen and cultural sensitivity and lifestyle changes, quitting the smoking. And oxidative stress is the main reason for oligoastenospermia. If there is no varicocele, we can give antioxidant therapy. That is all will be dealt in detail by Monica. And coming one word about the DNS fragmentation. Now it is widely practiced, but if DNA fragmentation is high, that indicates there is can be infection, varicocele, or other impairment of spermatogenesis. If it is not there, if it is a specific reason is there, we have to treat that. Otherwise, yes. Otherwise, we have to advise them to go for an IUI or ART at the earliest. IUI, the success rate is less than 15%, especially not visible if the count is less than 1 million, and semen preparation detail it will be told. And coming to that last, we have to always take the history and clinical examination, look for any treatable cause, go for a definite treatment if it is indicated, and get the confidence of the patient. So most of the time, we can treat the patient if you get some time, but we must not miss anything which is been treatable, and which are impending testicular failure must not be missed, and we have to advise accordingly. Thank you for patient hearing.
Thank you, Dr. Pesci, for your detailed talk on azoospermia, particularly male infertility, like DESA, and DESA, what we are calling and gene. Thank you very much.
Thank you, Dr. Fessi for that comprehensive covering of azoospermia and OAT. And now we will have a slight break from routine and go towards the female partner. So Dr. Monica Umbardent is there as our third speaker. She will be talking on ovulation induction for IUI. And I request the chairs, Padma Madam is there, to kindly do the honors by introducing our speaker.
Monica, do we have a slide or shall I do impromptu introduction?
We have a slide, ma'am. They'll share it for you.
Very dynamic, dynamic FOGSian, I should say, who is very committed to the cause of FOGSI, and we are very happy that at the very last minute she has agreed to address this very important issue, because it was supposed to be delivered by Dr. Bali. And Monica, we are very much looking forward to hear you address this important aspect, both ovulation induction and IUI, while coming together, how they make the it's sort of how it provides a mid-level treatment, and how we can maximize the success rate while addressing female infertility. Over to you, Monica.
Thank you, ma'am, for the kind
From
Monica
Solapur.
is
Yeah, I
the
forgot to tell that. Yeah, Solapur.
Public
you, ma'am.
Awareness Committee Chair. Thank you very much, Monica, for agreeing to do the talk.
Thank you, sir, for the opportunity, and thank you, Rekha ma'am, for the introduction. Can I just start sharing my screen,
Please
sir?
go ahead. We are already delayed. Please go ahead.
Is my slide visible, sir?
Yeah, you can go
Yes,
full
yes.
screen, please.
Is it fine now, sir?
Perfect, perfect.
Yes,
Thank
yes.
you.
Carry on.
Today we are dealing with an important topic for ovulation induction in IUI cycles. So for those, first thing that we need to do is, who is the right patient for IUI? In cases of unexplained infertility, where we have more than 12 months with normal workup, mild male factor infertility, where the total motile sperm concentration is more than 5 million post-wash. In cases patients who have anovulation in WHO group 1 and group 2 classification, that is PCOS and hypothalamic patients, and in patients who have cervical factor, that is hostile mucus and post-colonization. ASRM says that IUI with ovulation induction is appropriate as a first line of treatment in anovulatory women and in couples with unexplained or mild male factor infertility, but the tubes have to be patent. So before we start any procedure for IUI, bilateral tubal patency, adequate ovarian reserve, and partner semen analysis have to be done before we start the treatment. When should we not do an IUI is in cases where we have bilateral tubal block or absolute, which is an absolute contraindication. In cases where there is a high risk of ovarian hyperstimulation, where there is a severe male factor where the total motile concentration is less than 1 million. In cases of uterine anomaly, where we have a significant submucosal fibroid or a septum where insemination would not be possible. And in cases with advanced age or poor reserve, where AMH is less than 0.5 or antral follicle count is less than 3, then we should consider IVF directly. Now let's come to a brief refresher for a menstrual cycle. We all know that from day 1 to day 5, there is an FSH rise, which includes the antral follicle cohort. From day 6 to day 12, there is a dominant follicle which is selected, so estradiol will rise and LH will be subtracted. From day 12 to day 14, the estrogen peak will be there, LH surge will be there, which will be followed by ovulation approximately 36 to 48 hours later. And then corpus luteum will produce progesterone, so endometrium becomes secretory. Ovulation induction in cases of IUI will target the follicular phase, where we will be amplifying the FSH signaling to recruit at least 1 to 2 dominant follicles reliably. The goal is controlled ovarian stimulation and not hyperstimulation. So in cases of patients where we are dealing with IUI, we target that 1 to 2 follicles will develop, and it is mono or bifollicular development in an anovulatory cycle. Ideal outcome is 1 to 2 follicles of 18 millimeters. If there are more than 3 to 6 follicles, then we approximately counsel for the risk. And in cases where we have more than 14 millimeters multiple follicles, we should cancel the cycle. The first line of agent that we use is clomiphene citrate. It is a selective estrogen receptor modulator which blocks the hypothalamic E2 receptors, increase the gonadotropin releasing hormone pulsatility. It elevates endogenous FSH and causes follicular recruitment. The standard protocol that is used is day 2, day 3, and day 5. That is 3 to 7 is the most common that is followed on for 5 consecutive days, starting from 50 milligram per day and escalating to 100 to 150 milligram if there is no response. However, this has an anti-estrogenic effect on the endometrium and cervical mucus, and therefore it reduces the implantation rate despite ovulation.
So maximum 6 ovulatory cycles we can use clomiphene citrate, but we should not extend beyond this without re-evaluating the patients. Then should be used in patients where in cases with unovulatory fertility, where ovulation expected rate is 70 to 85% and pregnancy rate per cycle is 10 to 15%, and monofollicular development is expected in 75% of the cycles. Multiple pregnancy with CC is 8 to 10%, so we should always counsel these patients regarding the risk before we initiate. Then we have letrozole, where it's a third generation aromatase inhibitor. It reduces the peripheral E2, removing the negative feedback mechanism and increases the FSH. Unlike clomiphene citrate, this has no anti-estrogenic peripheral effects. So this is more preferred in patients who have PCOS with CC resistant cases, or in women with thin endometrium, in patients with poor cervical mucus, and in cases of unexplained infertility. Protocol usually is to start from 2.5 to 5 milligrams per day into 5 days, starting from day 3 to day 7. There is a short half-life, therefore it is cleared before implantation. Now, letrozole live birth rate is in PCOS patients is approximately 27.5% as compared to clomiphene. It has better endometrial thickness, whereas clomiphene has anti-estrogenic effect. And there is a lower chance of multiple pregnancy as well as OHSs with letrozole, whereas there is a high risk as compared to clomiphene. Letrozole is now preferred as a first-line treatment in PCOS, but it is still an off-label use for ovulation, and therefore an informed consent is mandatory. Both these agents are acceptable for unexplained infertility, and there is no clear superiority which is demonstrated in either of the groups. When actually are we going to escalate to gonadotrophin? So if you have 3 to 6 failed oral agent cycles with letrozole or clomiphene citrate, and there is no follicle development even at a maximal dose, and in those patients with hypogonadotrophic hypogonadism where endogenous FSH is absent, then gonadotrophins could be considered as a second line after the failure of the oral agents. We could use urinary FSH, combined HMG, recombinant ones, or the highly purified ones. However, there is no significant difference in pregnancy between the recombinant and the urinary FSH. The choice may be guided by the cost, the route of administration, and the patient preference. Now, first, we have the step protocol where we start with 50 to 75 international units from day to day 3 of the cycle, which could be given subcutaneous or intramuscular depending upon the molecule that we are using. And the scan is scheduled on day 7 and day 8, where we assess the follicular response and then accordingly increase the dose to by 37.5 minutes if there is no response. The trigger is usually given at 18 millimeters in the form of human chorionic gonadotrophin. When we are using step-down protocols, where we increase, start with 150 milligram per of FSH. Then on day 5 to day 6, we assess the follicular response. And once the follicle reaches 10 millimeters, you drop the dose to 100 international units. And when it reaches around 14 millimeters, it will become 75 units. Trigger is given when the follicle reaches 17 to 18 millimeters. This mimics the natural mid-cycle FSH decline, supporting the dominant follicle, and it suppresses the other subordinate ones. And theoretically, this becomes a more physiological cycle, but there is a high risk of multifollicular response as compared to the step-up protocol, and with strict cancellation criteria. This is used in normo-ovulatory women with unexplained infertility, and where AFC is approximately 5 to 15 follicles. Now, when you compare the step up and step down, the first choice in PCOS and normo-ovulatory would be the step up protocol. And in those with normo responders, but with more experience, we will use the step down protocol. However, in recent practice, we also use a chronic low dose protocol, which is best in PCOS, where there is a high AFC or AMH, and there is a monofollicular growth in approximately 70% in patients, where you give a constant dose of 75 international units throughout the cycle. So practical day by day, when you have day 1, we have the first day where you have a baseline transvaginal ultrasound and the serum estrogen, which is optional. On day 2, we start with the oral agent of clomiphene citrate or letrozole or with gonadotrophin. Day 7 to day 8, we will start the follicular monitoring and we assess the follicle count and the endometrial thickness. Day 10 to day 11, we do a second scan, adjust the dose accordingly and assess the dominant follicle. On day 14 between day 12 and 14, the follicle once reaching 18 millimeters, we would give a trigger of HCG. And IUI is usually performed 36 hours to 40 hours post-trigger. Now, timing may be plus or minus 2 days depending upon individual response. Transvaginal ultrasound is the gold standard for monitoring of ovulation induction in IUI cycles. It says allowing us a real-time assessment of the follicular response, the endometrium, and the detection of over-response to our drugs. So this we have seen as the baseline scan, the mid-cycle scan, and the pre-trigger scan are the 3 mandatory scans that we would do for all ovulation induction cycles. What are we actually looking in the scan is the follicle size, where the dominant follicle reaches approximately 70 to 18 millimeters, and the number of follicles that have grown. The endometrial thickness should be ideally between 70 to 8 millimeters at the time of trigger, measuring at the thickest point in the longitudinal plane with echogenicity, and also assessing the Doppler pattern, and also assessing the baseline functional cyst more than 15 millimeters or delay in the starting of gonadotrophin, or you can also aspirate this cyst transvaginally ultrasound guided. Now, endometrial thinning, how thick is enough when you want to do an IUI? Beyond the thickness, what we actually see is the trilaminar triple pattern with the best implantation rate. A homogeneous echogenic endometrium would be suggestive of premature luteinization, which is a poor sign. If the endometrium is thin, less than 7 millimeters, then you should consider low-dose estradiol supplementation, switching from clomiphene citrate to letrozole or gonadotrophins in the subsequent cycle. Also, addition of aspirin may be done, but it has a limited evidence. And if the endometrium still persistently remains less than 6 millimeters, then we could cancel the cycle. Now, when we are using clomiphene citrate or gonadotrophins, there is a risk of OHSs and multiple pregnancies, and especially in patients who have AMH more than 3.5 or with antral follicle count more than 20 or are having severe PCOS. If the patient has a history of previous hyperstimulation, and if you see a rapid estradiol rise, then these are the patients who have a risk factor for OHSS. The multiple pregnancy risk with clomiphene citrate we have already discussed as 8 to 10% are twins. With gonadotrophin IUI cycles, 20 to 25% if there is unmonitored cycles, and triplets and above have the most dangerous outcomes in form of early threatened preterm and the neonatal morbidity and mortality, and therefore we should cancel if we see more than 3 follicles developing. What are the other cancellation criteria? When to stop or when to convert a cycle that we should consider is if the follicle remains 14 millimeters and more than 14 millimeters, you see 3 or 4, then we should roll the trigger and advise barrier contraception. If there are multiple follicles and the patient has a strong desire to proceed, then this could be converted to an IVF or ICSI cycle with consent if the facility is available. If there is not applicable to IUI cycles, but withholding gonadotrophins for 1 day would decrease the number of follicles that are stimulated. If multiple follicles are unavoidable, then GnRH agonist trigger would reduce OHSS as compared to HCG. Now, usually the trigger that we use is urinary HCG, that is 5,000 to 10,000 gold standard, because it has a long half-life. It maintains an effective LH surge, and there is a higher risk of OHSS in patients who have multiple follicular development. In those patients, we could go ahead with GnRH agonist trigger. Then recombinant HCG 250 milligrams subcutaneous would be equivalent to the urinary HCG of 5,000. And once the leading follicle is 17 to 18 millimeters with endometrium more than 7 millimeters, not more than 2 mature follicles, we would give the trigger. So ideally, once you give the trigger, the IUI has to be timed at least 36 to 48 hours later. So we prefer giving the trigger in the evening so that IUI could be done in the morning hours to plan our practice. And IUI process, even swim up or densing 20 depending upon the semen analysis of the patient, we could choose the method of preparation. And there is no significant benefit which is performing earlier than 36 hours. Sperm survival of around 48 to 72 hours in utero provides a natural buffer. So if we want a better result, then we should decide between single and double IUI also. So, however, studies show that there is no statistical significance if you're doing a single IUI or a double IUI. But if the patient is insisting and if you want to do a double IUI, the first has to be at 24 hours and the second at 48 hours. But it's still increasing the cost and patient inconvenience and the clinic burden without much consistent clinical benefit or a live birth rate. So, is luteal support necessary in these patients? That unlike in IVF cycles, luteal deficiency is iatrogenic, whereas in ovulation induction IUI cycles, we usually preserve the corpus luteum and therefore luteal support is weak and inconsistent. However, micronized progesterone 200 to 400 milligrams per day from IUI to beta HCG or doing a UPT after 14 days, and we use prolonged at least up to 12 weeks without a confirmed viable pregnancy, we should be avoided. Now, in special considerations, we have letrose, which is preferred to pervitin citrate in PCOS. In unexplained infertility, ovulation induction IUI gives you a modest benefit over expectant management. And in mild male factor, it significantly improves the outcome versus IUI alone. The role of addition of metformin, low-dose aspirin, corticosteroids, and antioxidants. Usually, these are adjuvants which are used in IVF cycles. These increase the burden of treatment in an IUI patient and with a little less efficacy, which is proven, and therefore it is an extra burden to the patient. So, only aspirin could be used, which improves the endometrial blood flow. So how many cycles should we consider before we move on? So usually 1 to 3 cycles of standard ovulation induction and reassess after 3 cycles. We review the diagnosis, optimize protocol, and consider gonadotrophins. After 4 to 6 total cycles, we should recommend IVF, especially if the age is more than 35 or if the patient has diminished ovarian reserve. In cases of special circumstances, immediate IVF if age is more than 38, AMH is low, and in cases with severe endometriosis or bilateral hydrocephalus. Generally, what we counsel is that there is a per cycle success of 10 to 15%. Approximately in cumulative 6 cycles, there is more than 40% chance of pregnancy. In 8 to 10% with clomiphene citrate, there is a chance of multiple pregnancy, and in less than 1% of patients, there is an increased risk of ovarian hyperstimulation. What are the common mistakes that we do is we start stimulation without ruling out pre-existing cyst or confirmation of anal follicle count.
Your time is up.
Yes, ma'am, only one slide is remaining. Triggering at less than 16 millimeters or more than 22 millimeters and ignoring the endometrium and reporting only the follicle size, which is an important implantation variable. Proceeding with more than 3 follicles, which is the most common preventable cause of high order multiple pregnancy, and continuing beyond the recommended cycles because IVF delay referral, particularly in women more than 35 years, it would do a significant harm. What are the key takeaway is that we always confirm the tubal patency and semen analysis before we start any ovulation induction and IUI treatment. Using letrozole as the first line for PCOS, performing a baseline and a mid-cycle transvaginal ultrasound, aiming for at least 1 to 2 follicles of more than 18 millimeters and cancelling if there are more than 3 mature follicles. Trigger to be given at 18 millimeters, at least IUI approximately 36 to 48 hours later. Using single IUI as standard and double is not routine. Preferring a low step-up protocol in cases where there is a resistance to letrozole or clomiphene citrate. Limiting to at least 3 to 6 cycles and referring promptly to IVF. Counsel the couple on realistic per cycle and cumulative success rate. Thank you for your patient listening. I think I've completed my talk.
Thank you, Dr. Monica. Fantastic slides, amazing presentation, and at very short notice, we are really indebted to you. Thank you for gracing the occasion.
Thank you, sir.
And we have closing remarks from all the chairpersons for the first session, please. Dr. Uday Tanawala, sir.
It was a wonderful session and very good practical points, even in the last lecture, which we take home. One question was, what about the long clomiphene protocol? Do you give it for 10 days or 15 days rather than switching to gonadotropins, or do you want to take the questions later? Your call.
I think the questions can be answered in the chat box, sir, since we're already delayed. Can we have closing remarks from Dr. Narhari? He's been logged in for quite some time, but he hasn't spoken so far.
Sir, good afternoon. I was listening very carefully. All the speakers are excellent for their vivid and lucid presentation, starting from the seminal analysis. Then Dr. Priscilla is the about this azoospermia, and then the last but not the least, Madam, regarding the ovulation induction and taking all through about the physiology and what are the procedures. It's really a very informative, and thank you all the speakers, and thank you Pratik sir giving this opportunity. Thank you, sir.
Not at all, sir. Most welcome. Dr. Padmarika ma'am?
I think I second what the other chairpersons have voiced. Very pertinent talks, very pertinent issues, and very effectively addressed by the speakers, and making it very interesting too.
Thank you for being here, ma'am. Look forward to your participation more actively in ICOG activities. We'll really learn a lot from you.
Thank you, Dr.
I,
Padmarika, for joining.
Thank you.
I
Thank you,
saw
Dr.
Dr. Sarita Valera briefly logged in. If she is here and if she wishes to
She's busy
speak,
with her
she's my
practice.
co-convener.
Don't disturb her.
Yeah, she's here.
Madam is there.
Sorry, Pratik, I'm here. I'm listening. Yeah, I'm enjoying all the deliberations.
You're actually logged in from two devices. We can hear an echo.
Correct.
Wherever she goes, she's carrying.
Thank you
So
very
thank you
much.
very much to the
Thank you, Sheila.
chairpersons of the first session. It was lovely having all of you here. Excellent evidence-based talks, all the three speakers. Dr. Monica, we can proceed with the next session.
So with this, without wasting time, we can go for the second session. Second session, we have we invite the chairperson, Dr. Sujata Kar. Dr. Yukti, okay, I think she doesn't need an introduction. She is has right from the graduate times it's a gold medalist and very much academically active. I think, and she is has reviewed many articles and contributed immensely. We are happy to have you as a chairperson. Next, we have Dr. Yukti Vadan. Okay, she is the director and consultant of Yukti IVF and Gynecology New Delhi, president of DGF Forum West, and she very much active in all the circles. And very much academically, she has contributed lot and into the books and also to the awarded a lot of awards. We welcome Dr. Yukti. Dr. Monica, carry on.
Thank you, FOGSI sir, for introducing the first two chairpersons. Now I take extreme pleasure in inviting to chair the session two, Dr. Vaidehi Marathe from Nagpur, a very accomplished academician, a very vibrant personality, and a dear friend. She is practicing since the last 28 years and is the recipient of the coveted MS Signature International Award. And Dr. Vaidehi, I think she'll be joining soon. And the last but not the least, the chairperson is Dr. Deepa L. Masan from, Madam is from Delhi.
Jaipur.
Yes. So we welcome Dr. Deepa Masan, who is a senior professor of OBGY at JNUI MSRC, president of NARCHI, vice president JOGS.
Monica, you can be near to the mic. I think your voice.
Yes. Okay. So Dr. Deepa Masan is our last chairperson for the session. And we welcome
you for making me a part of it.
Welcome.
I'm privileged to be a part of it.
Yeah.
Thank you.
So
Persons, please introduce the speakers.
Yeah.
First speaker.
The first speaker is Dr. Kersi Avri, and I would request the chairpersons to please introduce Dr. Kersi, sir.
Good afternoon, everybody. Thank you very much for your kind introduction. And thanks to Pratik, my friend Madhuri, and all of you for it's a great thing that you all are doing a very nice webinar, especially today's was the fertility one. Female fertility was, I think, yesterday, and today is the male fertility. In this session, we have also some really great speakers, and it gives me a real great pleasure to introduce the first speaker. Kavari, who's an embryologist. He has 18 publications in Indian, including Indian and international journals. He's been a postgraduate teacher in life sciences for many years, and his special areas of interest are ART, troubleshooting, cryobiology, electron microscopy, and cytology, essentially everything to do with the lab. Currently, he's working as the founder director of Embryology Academy and Research Training. And he is the chief instructor in ART Training Center, working as a collaborator in many ventures. So I would like to invite Dr. Kalsi to give his talk.
Yes, so good evening to everyone.
This talk is, I think, cement preparation techniques. Very
Yes.
important. Okay.
Yes.
Welcome, Dr. Kalsi.
Yeah. Am I loud and clear? Am I
Yes, sir,
audible to
loud
all?
and clear. Please go ahead and
Perfect.
share.
Yes, sir. Yes, sir.
Thank you
I'll
for
be-
all your contributions to the reproductive medicine course. We really
Sure,
appreciate
sir.
it.
Not an issue at all. Anytime. Welcome. One second, I'll share my screen. Is my screen visible?
Not yet, sir.
One second. Yeah, now it's okay?
Yeah,
Yes,
perfect.
sir.
Go ahead.
Fine, perfect. So we'll be talking about sperm preparation techniques. Now, sperm preparation technique is a very vital part of any of the lab-oriented procedures for ART, whether be it an IUI, whether be it IVF, or whether be it conventional ICSI, because here we are getting a chance actually to handle and manipulate one of the most motile cell of the body, and at the same time, the tiniest cell of the body, a very dynamic version, which carries literally a load of DNA as far as the males are concerned as such. Now, this technique is the first or the initial one which helps us regulate the systematic step-by-step methodology of inducing or helping an infertile couple achieve pregnancy. Now, what do you mean by sperm preparation? Sperm preparation is a simple word, means to isolate the sperm from the seminal plasma post-ejaculate, to capacitate it, to make it activated, and to optimize its chances of fertilizing a metaphase 2 oocyte. The challenge, one gamete is handled in vivo, one gamete is handled in vitro. Right? But whatever be the scenario, later on subsequently, even in advanced techniques like IVF and IUI, IVF and ICSI, sperm preparation stands as the backbone. So with this, I just proceed. This is intrauterine insemination. Our goal, our logic, to increase the number of sperm qualitatively and quantitatively, which reach the tubes subsequently to meet an advancing ruptured oocyte in the tubes. Now, this is optimized by what we call it as sperm wash, or the chemical orientation, what we call it as capacitation. Now, we all know that here we have to just monitor the patient or the male from the number of semen analysis prior to the investigation or prior to him branding. Now, to know that, we have all our guidelines, right from 87 to 2021. And if you see this table properly, majority of the parameters are a little wishy-washy up and down. But the most challenging part dips in the percentage of normal forms, which in 87 were 50, and in the latest guidelines have crashed down to a mere 4. Now, why is the sperm so much important? Because the sperm DNA, or the mammalian acrosome, the eukaryotic DNA, is made up of compactly tied or compactly packed 6 to 7 times its capacity in the acrosome. So it is like a bubble which is ready to burst, provided we give it optimal conditions in what we call it as the ovarian cytoplasm, or the oocyte cytoplasm. When it goes in, subsequently it decondenses, the DNA is spread out, mixes, and the first step for a life, the 2pn stage. Now, this is vital as to how the sperm is modulated, how the sperm is activated, subsequently capacitated, so that it gives an optimal performance. Now, semen wash, what does it actually do? It mimics the crucial roles of estrogen dominant cervical mucus in a natural condition. Now here, we have to take into consideration, number one, the environmental stress, number two, the physiological stress, and number three, the osmotic stress, which inadvertently affects the pH of a cell, which is very important for any cell to maintain from vivo to vitro condition. Apart from that, in the upper bulleted points, I have written what are the other plus points of semen wash. Now, what happens? It is not that we just harvest the best sperm, we compact them into a pellet, zoom them up, they go swim up, natural selection. There are many chemical changes which take place when we do a semen wash or when we eliminate the seminal plasma from the sperm or from the complete plasma membrane of the sperm. So this chemical process is called capacitation. It's a functional maturation of the spermatozoon. There are many chemical changes which take place via the sperm membrane, which affects the receptors which are made available, especially removal of the glycoprotein layer, because the sperm acrosome is like an onion peel. There are a number of membranes over it. Glycoprotein is the most important. Once the glycoprotein is eliminated, the area of the acrosomal cap is altered, slightly improvises the morphology, and as we know, morphology is very important for the initial part of the sperm acrosome to adhere to the ooplasm or the oolemma, and subsequently it goes in and starts fertilization. So it's a continuous process which takes place else otherwise in the female genital tract. The bottom line is to prevent the cellular trauma on the sperm, we have to regulate, modulate, and improvise our sperm preparation techniques so that we give least stress as far as the pH, as far as the osmolarity of the cell is concerned. Now, this in a nutshell will explain you what capacitation is. Hyperactivated motility, sperm gets capacitated, improves the acrosome reaction, and these are all the peripheral knickknacks which take place during an ideal sperm wash, whereas a sperm gets capacitated by either of the two procedures which I'm going to subsequently follow up. Yes, so this is the general, I'm sorry, there was a little problem, 1 second, last viewed, okay. Yeah, now this is a step, collection, processing, harvesting, and ultimately capacitation. A routine sequential biochemical event in the maturation of mammalian spermatozoa before it is made competent enough to fertilize an oocyte. Whether you do it for high intrauterine cervical insemination, IVF, or ICSI, eliminates the seminal bacteria, which I have listed here. Of course, decreases the risk of HIV transmission, but to wash HIV-infected semen sample, there is a little modified procedure. And apart from that, removes all the debris, the cellular debris, the premature cells, pus cells, phagocytotic cells, CAS, abnormal sperm, immotile sperm, etc., apart from the disease-carrying seminal plasma. Now, how will we judge it? Tell the gentleman to go in for routine semen analysis at least thrice, a 3-week interval, and 3 days abstinence prior to each collection. And this is what an ideal semen report should register, so that it becomes easy for the gynecologist to understand the etiology and subsequently allot the proper procedure to the couple. Terminologies: normo, oligozoospermia, astheno, terato, necro, azo, OAT, and aspermia. Based on these types of motility, morphology, usual count, kinetics, amount present, nature, etc. So these are the nomenclatures which every andrologist or embryologist or semenologist should be well aware of. Now we come to the first method. Let's imagine you have got a good ejaculate, a good volume, a good kinetics, progressive motility is fine, linearity is fine. So what we would try to do is try our level best to go in for the proper natural selection. Principle is simple. It is based on the well migration of the motile sperm, which have been compacted by centrifugation, subsequently let loose, zooms up, and we collect the top aspirate. It's mostly the gold standard. But you have to register. It should be normospermic or mild to moderate oligoasthenospermic. It doesn't interfere in any other way except it dilutes the seminal plasma, eliminates the seminal plasma, washes the pellet clean, layer the pellet, gentle incubation, swim up, and we do the harvest. So step by step, I would like to tell you, conventional swim up, the first is assess the semen sample, or what we call it as a spot analysis. One drop post collection, post liquefaction, because a viscous sample is a nightmare as far as preparations are concerned. They don't form the pellet well. There is a lot of infection. The media doesn't mix well. Capacitation doesn't occur well. So the survival and the viability both go for a toss. So the first thing is use your sperm media. Now, sperm media is nothing else but a salt saturated substrate with hippies as a buffer. So this will need incubation at 37 degrees because that's an optimal temperature, which is ideal for all the gametes, whether be it oocyte or whether be it sperm or the embryo or the blastocyst, for their optimal survival. Because at this temperature, balanced with a proper pH and negation of osmotic stress, the survival is enhanced. So, well, judge the sample, dilute it 1:2 or 1:3 or 1:4. The more you dilute, the better it is to dilute the seminal plasma, which after centrifugation, you will get a pellet. Check the pellet consistency, discard the supernatant. Don't disturb the pellet. Here, important point to be noticed, please don't over centrifuge, because all foreign books will give in G-force, local Indian books will give in RPMs. So don't mix between the two. Both are miles apart. 300 G is ideal for the sperm or till 1500 RPM, because if you spin for a longer time, you are giving oxidative stress to the sperm, membrane trauma, increase of ROS, and therefore the viability or the retrieval rate or the success rate will crash out completely. Because a sperm as an animal cell is bound by plasma membrane, trilamellar protein lipid, fluid, very sensitive to stress. So a crack, disturbance, tear, or a rupture will bring the viability to zero. So please pay special attention towards the centrifugation force and to the timing. Well, step number 3, discard the supernatant. Step number 4, resuspend the pellet in pure media, of course, which is always at 37 degrees. The second wash will eliminate the chemical contaminants. Spin, discard the supernatant. Finally, when you get the supernatant again post second wash, layer it delicately without disturbing the pellet and keep it for incubation in a plain incubator. Remember, hippies media or the sperm wash buffer which contains hippies has to be incubated in a plain incubator, never in a CO2 incubator, which are always present in a CO2 or in an embryology lab. Because when an IVF lab is there, IUI is a part and parcel of it. It's a subset of it. Because hippies is totally non-compatible with carbon dioxide. It will crash down the pH to acidic and the sperm retrieval will be next to zero. But if you are using bicarbonate buffered media, you can use a CO2 incubator, but 99% of the time sperm preparation is done only in a plain incubator. So what happens? Pellet, layer, incubate. Now a little bit of physics. When you spin, centrifugal force will pellet down. When you stop, centripetal force will start zooming up the pellet. The media on the top, what it will do? The media on the top will loosen the pellet, as a result of which the sperm will be liberated. And the excellent sperm with fantastic kinetics will start migrating up. So this is a natural selection. That's why we call it a swim up. The bottom part will be consisting of all the debris and the unwarranted material. Don't wait for a very long time thinking that the longer I wait, the more the sperm will be recovered. Yes, the more sperm will be recovered, but eventually with the passage of time, even abnormal sperm will start zooming up. So you have to maintain a well-balanced ratio between your initial spot observation and think of it. 10 to 15 minutes post-incubation, fine, perfect. Take the top aspirate, check it before giving it for insemination. Because there may be times where even in the post-wash, many times we see presence of a few premature cell, pus cell. So in that inadvertent happening, we used to request, please don't do an IUI, do an high intracervical insemination, because we don't know how much concentration in the 0.4 or 0.5 ml of aspirate which we inseminate, the premature cell content might be. So this procedure is a gold standard, 99% followed in case of excellent semen samples or normospermic semen samples, based on the principle of natural selection. Now coming to the next procedure or the next step, double gradient discontinuous separation. Poor quality sperm, OAT sperm, kinetomatics are poor, count is less. Because as long as a person produces his own semen, even the count is less, even less than 1 million or 2 million, he has a right to use his own sample. Sorry, you cannot substitute any donor for the thinking, oh, count is less, you might not happen. There is a wishful thinking as such. So the basic is 2 gradients are like 2 filter beds. And it contains tiny, small, silane-coated colloidal particles. Layer them one above the other. Don't mechanically mix them. Suspend not more than 0.5 ml of liquefied semen on the top. Subject it to centrifugation. So this is called buoyant density separation method till there is an isopycnic point depending upon the weight. So in this box I have mentioned over here, a morphologically normal sperm has a good density of greater than 1.10, whereas abnormal sperm, even though it may be morphologically normal, will have the density less than this. So obviously they are the ones which will be subsequently trapped into the gradients, into the 2 interfaces. So this is what I have told the method as such. Prefer a conical tube. Now this is exactly how the procedures are done. High gradient, lower gradient. Different companies have got different gradients. As long as the concentration is different between the 2, there is no need to worry, because logic is subsequently filter, filter, and filter. So when it is spun, look at the different separations at different levels. Light white blood cells in the first interface, abnormal sperm in the second part, then the second interface, and what we get down below, a teeny weeny pellet which consists of sperm, number 1, which are morphologically normal, near morphology. I'm not asserting that they are 100% morphologically normal. And number 2, the nuclear density of the acrosome is much to an advantage. So these ones are the best ones which we use for ICSI as such. Because beyond that, in spite of so many add-ons available today in the market, you can't say with an authenticity that this is the best sperm, this is the best oocyte, or this is the best embryo. No, it is nature. Let us treat them like cells first before branding them sperm and eggs and oocyte. So coming back to the procedure, selective filtration down the line, pycnotic, depending upon the weight, the pellet is collected, a 0.1 ml of the aspirate is taken up, mixed with the media, incubated prior to giving for insemination because this media does not have any nutrition. The small pellet which is pinched from the bottom is mixed with the EPS media, albeit at 37 degrees. And please note, these gradients before being used have to be brought at room temperature. A slightest cold, the sperm which are layered on the top will be subjected because of cryoshock. They will become non-motile. So there are certain tips and tricks which in my last slide I will tell you. So what is what? In a swim-up technique, what's to be noted? The sperm wash media should be always at 37. What does the first wash do? I have seen people just spin once, take it top, no, in the single spinning, you can't eliminate the seminal plasma totally. There is always a presence. So that's the reason many times in conventional IVF, that's preferably if people are doing conventional, because nowadays the hype is much towards ICSI for all. That's not my concern as of now. So in the first wash, dilute the seminal plasma, so it's easier to remove. Second wash eliminates the physical debris and chemical contaminants. Layering should be gentle. Don't mechanically disturb the pellet. Don't layer more than 8 because it will lead into dilution and you are not going to inseminate 1 ml or 2 ml. You are just going to inseminate 0.4 of the sperm-rich aspirate. Please prefer an incubator over a hot block. I have seen many labs incubating in the hot blocks. An incubator, what does it do? It warms by convection. Whereas in a hot block, it warms by conduction. So a slightest temperature difference of even 0.4 degrees, kinetics are messed up. Prefer a round bottom sterile tube because the area is large. The pellet will be flattened. The recovery will be higher. And please ensure the semen sample is liquefied. Now coming back to the tips and tricks of double density gradient.
Apologies for interrupting, sir. You will need to wind up. We are over
Just
time.
two slides. Sir.
Yes, thank you.
The sperm wash should be at always 37. Gradient should be at room temperature. Don't layer more than 1 ml and don't layer less than 1 ml. Please, there is a standard pattern. It's a selected protocol. When you layer, don't mix. Don't layer more than 0.5 ml of semen. Aspirate the bottom part, 0.15 to 0.2. Prefer a conical tube so that the advantage of you getting a pellet is enhanced. And last, ensure that the sample is liquefied. Now that is what I call why not to over centrifuge, because it causes elevated DNA damage, increases ROSS and greater cellular damage. So these are all the trauma which we inculcate on a sperm because of our abnormal technique of centrifugation. Howsoever excellent a sample will be, this will completely mess up the entire population of the sperm. So these are the patterns set as per WHO organization, the speed, time, and the alternatives. Key consideration, please consider this, maintain the pellet stability. And in a nutshell, select the sample, judge the kinetics, think of a technique, justify the incubation centrifugation time, count in ml, count per ejaculate, total motile sperm count or the functional count is very important because what we are trying for the maximum recovery rate. What we are minimizing? Trauma, ROS. So the recovery rate post-wash should be greater than 35% of the TMSC. Thank you very much. That was my last slide because I was handcuffed for time, so I had to really rush it up. Thank you for a patient hearing. I can welcome any questions.
Thank you very much for a great talk,
Thank
sir.
you very much, Dr. Kursi.
Yes, sir. I'm sorry, I had to literally speed through.
So,
Can we have the introduction of Dr. Amit Patki?
So I request our chairpersons to kindly introduce our second speaker for the session, Dr. Amit Patki, sir. He will be speaking on paternal aging and its impact. And I request Dr. Yukti to please do the honors.
Very good afternoon. And I would like to thank Dr. Pratik Tambe, Dr. Sheila ma'am, and Dr. Madhuri ma'am for calling us, all of us here. And to introduce Dr. Amit Patki, sir. Sir is the Medical Director of Fertility Associates, Mumbai. He's also been the Honorary Associate Professor, KJ Somaya Medical College, and at Khar, Hinduja, and Surya Hospitals, Mumbai. And he's been the Governing Council member, ICOG, Vice President, ESAR, General Secretary, And the screen has changed, so I think sir has logged in. Over to you, Amit Patki sir.
Hi, a very good evening. The reason is because your slide is almost 10 years old. That's why I wanted to put on the latest slide. Thank you very much. And thank you to Dr. Pratik and Monica and Yukti for this kind invitation. And thank you, Monica, for allowing me to go ahead because I've got another lecture at 6 o'clock on another channel. So thank you very much.
Welcome, Dr. Amit.
Hi, Sheila. Hi, good evening, Dr. Sheila, and thank you very much. And I think I must congratulate ICOG for these excellent series that you are doing.
Thank you.
So today I'm going to speak on paternal aging, cracking the code of men's biological timekeeping, as we say. So when we talk of aging, the first thing that comes up in our mind is women aging, and we know that elderly women can be a challenge not only to conceive but also in pregnancy. But is aging only a woman's problem? It looks like that because when you look at different magazines and even science magazines, we find that it is always the women that are put up on the front page as for aging. But believe me, it could just men like women carry a biological clock when it comes to reproduction and the ability to produce optimal embryos after IVF procedures. And hence it is important that we talk about paternal aging because that may not exactly affect their fertility status, but it definitely affects the offspring's health. James Crow, who has been a professor emeritus at the University of Wisconsin, has said that the greatest mutational hazard in human population at present is fertile old men. And this may sound very, very harsh at the moment, but this is the fact that the genetic health of the human species is now facing a serious threat because we have a large number of men beyond the age of 45 and 50 who are having children. And there are certain examples of celebrities that are put up where people like Rupert Murdoch at 72 and Robert De Niro at 68 and maybe Donald Trump at 59 had children beyond the age of 50. But paternal age and maternal age and the fertility that is related to age was known over 2000 years. And this is a classic picture which depicts a dialogue between Plato and his student Aristotle, where the student asked his teacher what is defined as the prime of life. And they say it is approximately 20 years in a woman's life and 30 in a man. And Plato goes on to explain that a woman at age 20 can start begetting children to the state and can continue to bear them until 40. And a man can begin when he's 5 and 20, which is 25, and he can continue till he's 55. And it is amazing and ironical to note that even our laws suggest the same approximate age that you can treat women. The student then goes on to ask the teacher, what happens if somebody has a child before or after? And Plato explains that it is an unholy and an unrighteous thing, and the child is an offspring of darkness and strange lust. So when we look at the male reproductive aging, it is called as a radical road to ruin because in an advanced male, in addition to the dysregulated cell metabolism, the environmental toxins, the unhealthy lifestyle of obesity, hypertension, diabetes, smoking, you have comorbidities which will diminish the antioxidant protection and will cause an imbalance in the redox potential and increase in the ROS generation. And although some amount of ROS is necessary for fertilization, dramatically increased ROS, in addition to reduced testosterone production, causes time to aging, increased time with paternal age for conception, can cause erectile dysfunction, subfertility, miscarriage, and sadly, mutations in the offspring. In addition to increased paternal age, we are seeing a systematic sperm decline at an accelerated pace globally. And in the last 50 years, there has been almost a 50% decline in sperms the world over. So in 1973, the average sperm count was around 100 million. In 2018, the average sperm count is approximately 50 million, with a drop of 1.16% per year before 1972. And after 2000, the drop is more steep and severe, minus 2.64% every year. So we know that through epidemiological studies done in the US, the mean age of fathers has increased by 3 years, from 27 to 30 years over the study period of 50 years. We also know that the percentage of fathers of newborns older than 40 and 50 have increased from 4% to 9%, and in those over the age of 50 has increased from 0.5% to approximately 1% of births are because of fathers over the age of 50. And this is seen through the race, through the region of the USA. So what happens when the age increases? We find that typically around the age of 45 and over, there is a steep decrease in the concentration of sperms. There is decrease in the semen volume. There is decrease in the motility and a decrease in the morphology. All the parameters in the sperm analysis decrease, particularly after the age of 45 and more so after the age of 50. Now, what is worrying in maternal age is that there is an increase in the aneuploidy percentage of the embryos. Thankfully, this is not seen with paternal age, and 2 large studies published in 2017 and 2019 have shown that advanced paternal age does not affect embryo aneuploidy, and this they have done by fertilizing young egg donors and doing a blastocyst biopsy. So when you look at these 3 groups, one which is below the age of 40 to 50 and more than 50, you find that the euploidy rates are almost the same. The aneuploidy rates are also almost the same. And the mosaicism in the embryos are also among the same. And this is one of the large studies using NGS. So why are we then worried if there is no increase in aneuploidies? It worries us because it affects the offspring health, and that is where I'm coming. It causes mutational problems, which unfortunately cannot be picked up on routine pre-implantation genetic diagnosis or even on amniocentesis. So advanced paternal age, we must understand that till now we focus on female age, but it is also important to counsel couples, particularly when the paternal age is over the age of 40, because it not only causes an increased time to conception, but more important, it causes mutational problem. I just move away a little from age and come to male reproduction and male infertility as a window for health in men. We know that in most women who are infertile, a majority of them have good health. But in men, when there is male factor infertility, particularly severe male factor infertility, it is considered as a harbinger for men's general health, and hence a multidisciplinary approach is necessary for such men. Now, when you look at these cancer incidents and male infertility, you find that there is a moderate increase in all cancers in males who have got infertility, with a moderate increase in prostate cancers. When you look at cardiovascular health, you find that the cardiovascular mortality in male infertility is high, with a moderate increase in all cardiovascular diseases. When you look at other health issues, diabetes, all immune disorders, rheumatoid arthritis, psoriasis, multiple sclerosis, and Graves' disease all have a moderate increased risk with male factor infertility. And why is this happening is, let me just take you to a little basics. This is the classic DNA, and these are all the base pairs that are linked to it. When you talk of DNA with damage, you have this DNA with multiple damages happening. And this is particularly found in elderly men, more than 45 and definitely more than 50, and those who are associated with metabolic disorders, obesity, hypertension, diabetes, smokers, alcoholics. So the number of ROS, which means that there is the ROS increases, and you also find that with male infertility or paternal age, the damaged DNA increases. And when the damaged DNA occurs in the human spermatozoa, it is associated with a lack of chromatin compaction, and this increases in two stages. The first stage, the spermiogenesis is impacted, increasing or giving you a high abnormal histone to protamine ratio. And this DNA, which is damaged, which is a vulnerable DNA, is subjected to attack not by nucleases, but by ROS. So when there is an increase in the ROS, you find that there is further DNA damage, and this DNA damage can lead to mutational disorders. Now, how was this diagnosed? Now, achondroplasia is known to affect amongst the large order children, the last born child. Now, quite often it was linked to maternal age, but it was Penrose and Weinberg who said that in a large order children, the last born child who has got this mutation is related to the paternal age. And Penrose in 1940 and 1955 said that in spermatogonial cells replicate every 16 days, so approximately 200 divisions by the age of 20 and over 660 divisions by the age of 40. In contrast, the oocytes undergo only 24 cell divisions, all but the last one occurs before a woman's birth. So all these divisions that happen and the DNA fragmentation in association with ROS can cause mutational disorders. So what is associated with advanced paternal age? Unexplained stillbirths, unexplained miscarriages, congenital syndromes like achondroplasias, Marfan syndrome, syndactyly, cleft palate, patent ductus, Down syndrome, preterm birth, preeclampsias, childhood cancers like retinoblastomas and ALL, and more important, neurodevelopment disorders like autism spectrum disorders, adult onset schizophrenias, attention deficit syndromes, and bipolar disease. So when you look at advanced paternal age and autism, this graph clearly shows you that as compared to young fathers at 20 and 30s, fathers over the age of 40 have a double incidence of autism in the child. Look at this graph for schizophrenia. Again, very clearly seen that in men over the age of 50, as compared to men at the age of 30 to 35, they have a double incidence of schizophrenia. So how can you reduce this incidence? you can try and reduce the DNA fragmentation by reducing the ROS. And how can you reduce the ROS? By having better lifestyle, reducing obesity, reducing smoking, alcohol, and by use of supplements. The most common that we use is CoQ10, but we also know there are two other major antioxidants, hypotaurine and glutathione, will help to reduce the ROS and the sperm DNA fragmentation, thereby trying to reduce these DNA mutations in the offsprings. And how did we come across? The eye opener in our unit was when we looked at 100 men who had come with no sperm abnormalities in the semen report, but having comorbidities and having one IVF failure elsewhere. We found that almost 24% of them were over the age of 40, 21 were diabetics or we picked up diabetes, 12 were hypertensive, obesity was present in 9 of them, smoking more than 25 cigarettes a day in 20 of them, and all this was perhaps missed in the history because unfortunately the semen report was normal. So when these men were treated for their comorbidities, put on antioxidants, we found that a significant amount of them, the count started getting better, the DNA fragmentation started getting reduced, and we found that we had almost 25 conceptions were recorded in the study group in the period that we were analyzing them for 3 months. And then we had a seminal paper which was published as an original article.
Sorry to interrupt you, sir. Your time is up.
Yeah, I'll take only 30 seconds in this journal. So, ladies and gentlemen, I think it is extremely important when you look at the couple to treat them holistically as a whole. Look at the age of the man, look at the comorbidities in the men, and then look at trying to treat the man as fervently as you would like to treat the female partner. Thank you very much for a patient hearing.
Thank you, Dr. Amit Patki, sir. Fantastic presentation and very unique thoughts. Thank you for sharing them with us. And I know that you've given this oration many times.
I think
But
it
on
is
the
one.
ICOG platform, we've not had this talk from you. So thank you very much.
Yes, but it is
Yeah,
one
go
of
ahead,
Sir's
Madam.
favorite topics.
Correct.
Even when during the presidential year of Dr. Amit Patki in ISAR, he did a lot of talks on male fertility. And we truly appreciate this talk, sir.
Thank you very much.
so
Thank
much.
you so much.
Thank you so
I
much.
wanted this to be there on the ICOG platform, and I thought he was the best person to deliver this.
Sure.
Thank you.
So we now have Dr. Monica Singh, who is one of the coordinators for today, and she's going to be speaking on medical management of male infertility. Monica is well known to all of us. She's a famous infertility consultant from Bhopal. She has a long track record of presenting so many papers at ESHRE, also travels to many other international conferences as well. She has her own web series, which she's been doing diligently for many years now. And currently, I think she's the president-elect. She's going to take over early next year for the Bhopal OBGYN Society. Also a contestant for a FOGSI chairperson election. Wish you all the very best. Please go ahead.
Thank you. Thank you, Dr. Prateek. And it's very difficult to speak after such stalwarts, but since the time is very limited, I better get going and start sharing my slides. So the topic given to me is tough. Am I audible?
Yeah, please go ahead.
Yes,
Right.
yes.
Thank you. Thank you. So let me start telling you about the source of my talk. The diagnosis and treatment of infertility in men, we saw all speakers overshoot 15 minutes. The sole reason being because each talk is so extensive that like compacting it in 15 minutes is a task in itself. but medical management of male infertility is not that vast, but I tried to give you a capsule out of it. And most of my presentation is derived from the American Urology Association and ASRM guidelines, which were given in 2020 and amended in 2024. So just to give an introduction, most of the preface has been given by my esteemed speakers before me. Male factor in 50% of the infertile couples presents to us. 20% cases, it is the sole cause. 30 to 40%, it is the contributory cause. And the goals of male fertility evaluation is to identify those conditions where it can be potentially treated by maybe medical management or surgical therapy, and other conditions where it has to undergo, the partner has to undergo ART, the couple has to undergo, but the partner's sperm can still be used. Then there's a group where there are alternative paths and the clinician has to counsel about donor insemination or adoption. And then there is a group of men wherein during investigation you find some specific health threats and genetic conditions which are going to affect not only the patient but also the offsprings. So you're going to counsel about that also. So basically, the physical examination takes you through key elements of examining the general body habitus, any endocrinological signs, the phallus, epididymis, vas deferens, scrotum, testis, and do not forego the digital rectal examination for the ejaculatory ducts. The statement evidences which I'm going to present in my talk are the AUA, or the American Urology Association Evidence Strength System. We all are very much aware of this system, which tells us about grade A evidence, which is high certainty, grade B, which is moderate certainty, and grade C, which is low certainty. At the same time, we talk about strong recommendations where the net benefit or harm is substantial. The moderate recommendations where the net benefit or harm of an intervention is moderate. A conditional recommendation where there is no apparent net benefit harm or it is very unclear or vague. And then there are some good clinical practice guidelines, for whatever we call GCPRs in our FOGSI language. Those are the clinical principle and expert opinion based on consensus-based judgment. The guideline statement 2 of AUA talks about semen analysis. 1 or 2 semen analysis are mandatory. At least 2 semen analysis obtained more than 1 month apart are recommended. Any one parameter does not indicate or predict infertility. The results should be considered collectively from multiple parameters. These are the WHO reference limits of 2021. And the statement 1 says that you have to do a concurrent couple assessment. Both partners should be evaluated parallelly, simultaneously at the time of initial infertility workup, because you do not want to do in a male evaluation or male problem, you want to avoid unnecessary female only treatment. After doing the parallel evaluation for the couple, you go on to statement 2, which is reproductive history plus semen analysis. So the guidelines have again emphasized the importance of a proper reproductive history and 1 or more semen analysis. The second semen analysis is especially important when the first one is abnormal or subnormal. Thirdly, wherever you find multiple semen parameters which are abnormal, as well as a history point which is particularly striking, do not take time to refer to a male reproductive expert, andrologist, or a urologist. When we interpret the semen analysis, we know that variability matters, and semen parameters in the same individual, even on the same day, are highly variable. So at least 2 semen analysis more than 1 month apart ideally are recommended. Multiple abnormalities have to be taken into consideration, and more the number of parameter abnormalities in semen, the more is the likely of infertility. And 1 to 6% of these men undergoing evaluation may give you a sudden diagnosis of a very surprising medical pathology, even a malignancy. So what are the odds ratio of infertility? As mentioned earlier, the chances of infertility increase with the number of abnormal parameters present in the semen. Now I come to the actual matter of my talk, which are the statements 5, 6, 7, 8 of the AUA guidelines. They deal with lifestyle, health, and infertility in males. So statement 5 and statement 6 appear to be very similar. I had to read them a couple of times in order to find out the difference. Statement 5 says you have to counsel infertile men on health risks associated with abnormal semen production, sperm production. And statement 6 says that men with identifiable causes of infertility should be informed of associated health conditions. So Dr. Amit Patki has told us about this problem where metabolic and other conditions, chronic conditions can be associated with abnormal semen parameters. These patients with abnormal semen analysis sometimes have higher rates of testicular cancer. Azoospermic men have higher rates of cancer in general and even a higher overall mortality rate, which is actually a very strong statement. So male infertility, as Dr. Patki has remarked before my talk, it is a harbinger of multiple systemic diseases as well as malignancy. So these are some conditions, specific comorbidities which are present with genetic conditions. We will not go through the details. Now coming to the medical and nutraceutical interventions for fertility. Clinicians can use from the basket available to them, which is actually not very vast. It is quite limited actually. Aromatase inhibitors are there, human chorionic gonadotropin, selective estrogen receptor modulators or SERMs. Please do not get intimidated by this term. It simply means either clomiphene citrate or tamoxifen or a combination of these drugs. For the male who is interested, these are the guideline number. It is guideline number 42, which are very striking statements. So I have put them as individual statements in a slide. For a male who is interested in current or future fertility, we should not be prescribing injectable exogenous testosterone therapy at all, which is a clinical principle. For infertile male with hyperprolactinemia, clinicians should evaluate the patient for etiology of the hyperprolactinemia and treat accordingly. This is an expert opinion. Clinicians should inform male with idiopathic infertility that the use of SERMs like clomiphene citrate has got very limited benefits as compared to the result they will get from ART. Clinicians should also counsel the patients the benefits of supplements. So many supplements are now available over the counter from internet, antioxidants, vitamins. All of them are of questionable clinical utility in treating male infertility. So the existing data is inadequate for us to recommend any specific agent for male infertility. This is a moderate recommendation grade B. For males with idiopathic infertility, however, there is one medication which can help, that is FSH, follicle stimulating hormone. Its analogs can improve sperm concentration, pregnancy rate, and live birth rate. This is a conditional recommendation, grade B. Now coming to non-obstructive azoospermia, many of the cases of NOA, Dr. Jindal will be deliberating after me, are taken for surgical intervention in the form of microtase. Here, clinicians' duty is to inform the patient that pharmacological manipulation using SERMs, aromatase inhibitors, and gonadotropins prior to doing microtase will really not help too much. So sometimes patients want to, give 1 or 2 months to medical therapy before going for microtase, though a few sperms may be seen in the ejaculate, but it is not a significant improvement. Coming to lifestyle and environmental risk factors, we are surrounded by them. Today, I was reading on internet the temperature in certain parts of India has touched 56 degrees Celsius this summer. So we are basically now in a hot air oven. Diet, there is low quality evidence that if a person switches from non-vegetarian diet and fatty diet to more fruit and vegetable diet, that is good for male infertility. Similarly, smoking, though smoking seems to be very harmful, there is very low quality evidence linking smoking to small reductions in sperm concentration, motility, and morphology. Similarly, with alcohol, there is reduction in sperm volume and sperm quality. Anabolic steroids, however, if they are ongoing usage, it can suppress spermatogenesis and interfere with fertility for a long time. At the same time, these risk factors should be given with a pinch of salt that the data on them is very limited. Alcohol can slightly lower the semen volume, lead to poor morphology sperms. Exposure to pesticides and heavy metals, lead, cadmium, DEHP, pyrethroids, they are present everywhere. Like whether you're using plastics at home or you're sitting in a car or sipping from a metal container or basically exposed to a particular environment, everywhere there are these heavy metals which can lead to poor semen. Hormonal therapies for low testosterone. I told you there are 3 drugs in our basket, aromatase inhibitors, namely letrozole. We know how letrozole acts. It blocks the peripheral conversion of testosterone to estrogen, so it increases the level of testosterone. So you can consider this for patients with testosterone deficiency, but it is not FDA approved. HCG acts like a surrogate LH. It stimulates the Leydig cells to cause production of testosterone, but again, it is not FDA approved. It is being extensively used in male infertility as well as hypogonadotropic hypogonadism. Coming to SERMs like clomiphene and tamoxifen, they increase LH, FS, and testosterone. Easy to use, widely used, not FDA approved. Exogenous testosterone is contraindicated in fertility. This is underlined statement 2. Do not prescribe exogenous testosterone therapy to males who are interested in current or future fertility. The scary part is they are long-acting testosterone. They cause negative feedback on HPO axis, suppress gonadotropins, cause oligospermia, azoospermia to the extent that full recovery takes years and some males never fully recover. There's an option of short-acting nasal testosterone which doesn't have sufficient data, and sometimes you can combine with them with add back of HCG, SERMs, and recombinant FSH, which again is not having a very good data behind it. Hyperprolactinemia has to be evaluated if it is persistent. Pituitary MRI to be done in the male partner. Dopamine agonists are first-line drugs, and you have to take history for drugs causing hyperprolactinemia in the male partner, opioids, antipsychotics, and antiemetics, the basics of our pharmacology. SERMs for idiopathic infertility are widely used and can improve sperm concentration, motility, and spontaneous pregnancy. But definitely such patients, if they move earlier to ART, that offers a lot of advantages and shorter treatment duration. FSH analogs for idiopathic infertility are well proved in statement 46, and we are using them. The typical dose of FSH is 150 IU daily over 12 weeks. You can vary the dose, and meta-analysis have given us improved sperm concentration and pregnancy rates with a conditional recommendation grade B. So these are all the supplements and antioxidants which are present over the counter. You can see this particular brand has got CoQ10, vitamin D, and zinc. Now, zinc has a positive role. Vitamin D has a positive role everywhere now. CoQ, Dr. Amit Patki talked. We participated in a study. But see, these are likely not harmful supplements. But tangible fertility improvements are unproven, and you cannot recommend any specific agent for any specific duration of time. Coming to hypo, it is covered by statement 40. It is a topic in itself. So just have to diagnose the etiology. It could be congenital hypo or acquired due to tuberculosis, sarcoidosis, etc. Treat the underlying cause, correct the reversible factor before carrying on the fertility therapy. The first line therapy is HCG. The dose we know is 500 to 2500 IU 2 to 3 times weekly. And you can add FSH and SERMs when needed and have a low threshold for referral to IUI or ART. Medical therapy before NOA, before microtase in non-obstructive azoospermia. Dr. Jindal will be talking on this in statement 47. You can use medical therapy, clomiphene citrate, letrozole, or FSH before microtase. It can cause an occasional, cohort of sperm to be present in the ejaculate, but as such, it will not cause any significant improvement. So my summary key takeaways are always do a parallel evaluation of the partners. Think of health beyond fertility. Do not overlook genetic testing. Do stepwise evaluation. The key messages are sperm banking is urgent before cancer treatment. Have a clear knowledge about it. Hypo we are going to skip today. And thank you very much for the patient listening. You must go through this male infertility algorithm, which is given in the guidelines. Thank you all for the patient listening. A humble request for my candidature as Chairperson FOGSI Infertility Committee, seeking nomination from all of you. Thank you.
Thank you, Dr. Monica Singh, for an excellent coverage of the topic in a very short space of time. Is Dr. Sunil Jindal said there? I don't see him logged in. So if he's not there, can I request the chairpersons to present their closing remarks for this session?
Sir has not joined yet.
No worries. Dr. Rajlakshmi, Dr. Deepa Masan, Dr. Yukti Vadhavan, can we have closing remarks from you before we
Yeah,
proceed to the
thank
panel
you, Dr.
discussion?
Prateek Tambe and Dr. Sheila Mane, for involving me in this perfectly, excellently structured workshop that is very much helpful to all young budding gynecologists. And I'm sure you are going to have your fan following further increasing day by day. And to conclude, all the topics were excellent, and these are must know things, and there are few things that even we have learned through these lectures and topics, so I'm sure everybody out here is benefited. Nothing further to say, everything is covered well. Thank you so
Thank you,
much.
Dr. Deepa, Dr. Yukti, and Dr. Rajlakshmi.
Yeah, hi, Dr. Prati. So excellent speakers and excellent topics covered. Dr. Karsi, Dr. Patki, and Dr. Monica, you really, done a great job. And to all the budding fertility, people who are adding to the fraternity. So male factor is also very important. Don't ignore. You're not just, most of our concentration goes in treating the females, but then the male partner is an equal component in the fertility process. So please don't ignore and take all the points, note them. It really adds to our knowledge. And thank you so much, Dr. Tambe, for inviting us. And actually, it's a great revision. It's a great learning again and again. So pleasure. The pleasure is all mine. Thank you so much.
Thank you for those kind words, Dr. Yukti. Raj, any closing remarks? I think she's frozen.
So hi everyone, good evening. So firstly, a great huge thank you to the ICOG team, Pratik, you and Dr. Mane, for actually arranging these sessions, because they really help us go back to basics. And there is you can't revise basics enough. And therefore, I always look forward to being able to attend whenever I can. Thoroughly enjoyed all the three speakers. Very to the point. That was a quick revision, and I really hope that the young kids that are joining in and who are looking forward to being fertility consultants will take away huge gems from here. Thank you.
Thank you very much, respected chairpersons, for doing the honors. Can I request?
Thank you, chairpersons and the
yes,
speakers for that second session. I think the surgical sperm retrieval techniques, even though I had covered the basics in my talk, so I think further anything we can have discussion. And without wasting time, we will go for the panel discussion on IUA case scenarios. We have can you show the slide of the moderators. We have the moderators, Dr. Sarath Bettena. Sar is a consultant reproductive medicine of Indigo Women's Center, Chennai. Is a member of lot of associations, and is a good laparoscopic surgeon also. We are
chairperson of TAPISA.
Yes, chairperson for the TAPISA. I'm coming to that. Okay. Second,
I don't want to waste time. Now we'll go ahead.
Just the second we have Dr. Kanjan. She's a professor from Moradabad.
Thank you, sir.
And
Thank you so much, sir.
okay,
She's our GCM.
okay. Okay, then we have experts, Dr. Arun Barawa. Sir is from the Assam Guwahati Apollo Hospitals in Guwahati, and also chairperson and academically lot of associated with lot of organizations in the all in over India and Northeast. We welcome you, sir. And another expert is Dr. Tarini Taneja. Madam doesn't need any introduction. She is the president of ISPAT Delhi State and Finance Secretary to South Delhi IMA and GC
She's
member
also
of.
our GCM.
Okay.
Thank you, sir, Doctor.
So over to moderators to introduce the panelists.
Thank you, Dr. FOGSI and Dr. Pratik. Pratik, we are all thankful to you for giving this opportunity. It's a great opportunity for us, and we will try to do our best for you. Thank you so much. Slides.
Yes, sir. Please introduce the panel
No,
members.
yeah, I'm going to, yeah, yes.
It is there. It is there.
Next. Okay. Next.
Shall I share the
Yes.
slides for you, sir? Sarath sir?
Yeah, no, I'm fine. Yeah, now we have the excellent panelists, no? So, yeah. I feel just start now. Waste one.
It is there. It is there on the screen, sir.
Yeah. Yeah. Okay. This is, yeah. That's important. Yeah. Okay. We have eminent panelists in our panel today, and Dr. Kunju Mohiddin is a fertility specialist from Birla Fertility, Kozhikode, and Dr. Himanshu Rai. Both of them are good friends for a long time, and he is from Srijan Fertility Clinic, Patna, and Madam Dr. Rajalakshmi Valvalkar from Cocoon Fertility Clinic, Pune, and Dr. Sandhya Rani Panigrahi, she's obstetrician gynecologist from Odisha, and Dr. Srishti Chaturvedi, endoscopic surgeon from Bilaspur, Chhattisgarh, and Dr. Vidhi Desai, endoscopic surgeon from Mumbai. With these eminent panelists, we'll start our program now. So the topic will be intrauterine insemination, the case scenarios. No, before we go to that case scenarios, I would like to give a brief about controlled ovarian hyperstimulation and intrauterine insemination. It's a common therapeutic procedure in infertility practice. It's a simple, less invasive, and less expensive procedure. The principle behind IUI is to increase the gamete density, both the oocytes and the sperms at the site of fertilization. The most important prerequisite will be patent tubes. According to Cochrane Review 2008, IUI corrects the subtle endocrine dysfunctions associated with ovulation, and IUI overcomes coital dysfunctions and abnormal cervical factors. Who are the candidates for IUI procedure? Dr. Kunju Mohiddin, are you there?
Yeah, I'm here.
Yeah, in your clinic now, I want to know now who are all the candidates for IUI procedure.
Yeah, thank you, Dr. Sharath, and thank you, Dr. Pratik, for giving the opportunity to be here. And the indications for the candidates for IUI is actually very limited. Basically, the very mild forms of male infertility, or the patients with the mild endometriosis who had undergone laparoscopy and the correction of the endometriosis surgically, an immediate IUI cycle will be beneficial. And more often in unexplained infertility, there are a lot of controversies. Even then, if the patient's age is in favor, the couple also is a candidate, will be a candidate for IUI.
Dr. Himanshu, are you there?
Yeah.
Dr. Himanshu?
Not working, but I'm here. I can listen to you and see you all. Thank you.
We are not able to see you, no? Yeah. Will you tell me, do you have any more indications for IUI in your clinic?
Yeah, in our clinic, like we used to have a lot of patients of azoospermia who are not willing for undergoing TESA, or have tried TESA and failed, or are not proper candidates of TESA. And
maybe because of cost effect?
Yes.
They may not be able to afford the expensive procedures like TESI and other things.
Our candidates, they opt for this thing, IUI for donor insemination. For homologous insemination, again, unexplained infertility has become a quite common thing, and now only after very conservative treatment for only 2 to 3 months or 6 months, people come for us with various indications. So unexplained infertility is another one of the common causes for which we are seeing patients who come for IUI.
Okay, then thank you. So coming to the indications for IUI, male factor infertility. In case of oligospermias, when the sperm fraction is total motile sperm fraction is more than 5 million, probably you can suggest them IUI. Unexplained infertility, when all the conventional infertility investigations are within normal, if the couple fails to conceive within 2 years of marriage, probably we can subject them for IUI. Endometriosis, as Kunju Mohiddin said, minimal and mild endometriosis are those who had surgeries for moderate to severe endometriosis. If you have restored the tubal motility, probably we can, tubal anatomy, we can subject them for COH and IUI. Anovulation, PMOS, polycystic ovarian syndrome, one of the common causes for anovulation. We can subject them for natural intercourse, but when ovulation induction is associated with IUI procedure, the chance of pregnancy are high. Coming to the cervical hostility or cervical factor infertility, where we can bypass the cervical factor infertility by doing the IUI procedure. Others include erectile dysfunctions, hypospadiasis, retrograde ejaculations, and most importantly, these days, semen freezing for the traveling husbands.
Dr. Sarath, could I add one more indication there?
Yeah, please, ma'am. Yeah, Dr.
So,
Rajalakshmi, please.
sorry. So, one more thing that we could consider IU as first line is for when you have patients who are serodiscordant. So where the normal intercourse could expose either partner to contracting HIV or hepatitis, IUI could actually become a first line because you can't allow them to have intercourse naturally. So I think we should
In this
also keep that in
particular
mind.
scenario, I have a question for you, Dr. Lakshmi. This one, husband is seropositive, and they wanted to go. Wife is seronegative. They are serodiscordant. No, do you suggest IUI for them?
Yes, because when you do a double sperm wash, the chances of transfer of the virus is very, very low.
But still, 5% chances are there. They say no.
Sir, but we could always cover that with an IV antiretroviral, one single dose. So under the cover, so even if you take a look at the WHO guidelines, because otherwise taking this patient directly for IVF, especially if they're economically not very sound, this is something that can be given a shot.
Thank you for the valuable inputs, Dr. Lakshmi. So coming to the basic procedure of IUI, the more importantly, controlled ovarian hyperstimulation for multiple follicle development, sperm retrieval and preparation, and insemination procedure. Coming to why we have to do controlled ovarian hyperstimulation for IUI. The principle behind COH is multiple follicle development, so that multiple follicles will be available at the time of ovulation and multiple oocytes will be available for fertilization. So to increase the number of gametes at the time of fertilization, we will do the controlled ovarian hyperstimulation. Then predictable follicle growth. Usually the follicle growth will be about 2 to 3 millimeters per day, and we will be knowing by doing transvaginal ultrasound guided follicle studies, we'll be able to know the follicle growth and when to give ovulated dose of HCG, and at the same time, we can see the receptivity of the endometrium, how there is a triple line of endometrium is there or not. And most importantly, we can time the ovulation and insemination, because time is precious for everyone these days. So patients will be in a hurry, and probably we can time the ovulation when the mature follicles are there, and we can time the insemination accordingly. Yeah, this slide, nice, beautiful slide. By putting the woman on ovarian stimulation drugs in the early part of the menstrual cycle, what happens? Those follicles that are destined for atresia, they'll be saved from atresia, and multiple follicles will be available for at the time of ovulation. Then coming to what are the factors influencing the controlled ovarian hyperstimulation? Dr. Sandhyarani, madam, will you enlighten us on this one? Madam, you are able to hear? You have to unmute. Dr. Sandhyarani, please unmute. Madam, please.
Good afternoon, everyone. Sir, I want to pass this question because I have a call from the labor room to attend that one, sir. Anyone
Sure,
please
sure.
take it?
No problem. Dr. Srishti, are you there?
Can I take it?
Didi, please go ahead.
Ji, sir. So, good evening, everyone. Thank you, Dr. Sheila Mane, ma'am, and Dr. Pratik Tambe, sir, for this opportunity. So there are various factors that can influence the controlled ovarian hyperstimulation. First being patient's age, her ovarian reserve, her AMH, AFC. So to see her ovarian reserve, her baseline E2, her FSH, and what kind of protocols that we are using, which protocol we select, what kind of sperm retrieval is done, what kind of preparation we do, and the actual insemination process itself, that all can influence.
So coming to the factors influencing controlled ovarian hyperstimulation, as Dr. Didi said, she has covered most of the things, but I wanted to enumerate again. Age is the most important factor about the success of the IUI in the patients, infertile couple, and obesity. Because of obesity, they may require more amounts of drugs, and the pharmacokinetics and pharmacodynamics will be different in obesity patients. Accordingly, we have to treat them. And most importantly, ovarian reserve plays an important role, which includes anti-Mullerian hormone and the anti-follicle count mainly. Coming to control ovarian hyperstimulation. Dr. Kunjumuddin, what's the favorite drug for you for IUI procedure for controlled ovarian hyperstimulation? Dr. Kunjumuddin, are you there? Dr. Himanshu? Riddhi, would you like to take this question?
Yes, sir. So my favorite is letrozole.
Yeah, letrozole. Okay.
Promotes
Why?
monofollicular growth.
Yeah. Why?
Yeah.
Why?
Sir,
Why?
sir, I'm back.
Yeah, Kunjumuddin. Yeah, please. Yeah, tell me, in your clinic, what is your favorite drug?
Yeah, see, theoretically, even though there are a lot of
Sorry, I'm
preparations.
not able to serve coffee for all of you, no, but
Yeah, we'll come to Chennai, sir. So
yeah, please,
theoretically, a lot of things have been explained, described, CC, letrozole, gontropins and all. But my favorite combination is letrozole and gontropin. So that will throw out at least 3-4 follicles. And that is the usual ovarian stimulation which I follow. And if some adjuvants required, I'll add to that, like metformin. That's it.
Yeah.
You can ask Dr. Himanshu Roy. He probably does more IUIs per day than any of us do in an entire month.
Hello. Yeah, okay. Dr. Lakshmi, Dr. Rajalakshmi, would you like to add anything?
No, I think he's covered everything.
Yeah. The main thing is that while the patient comes to you for IUI, before that, you have already can see the
Himanshu, first time I'm seeing you on the screen. Yeah,
Yes,
please go
sir.
ahead. Happy to
I
see you
think
after a long time.
30 years
No?
back when we had started our meeting. So it's 30 years is a big time. So it's very nice meeting you, sir. So when the patient comes to us for IUI, before that we can see her ovarian response, that what was her ovarian response in previous TI cycles or ovulation induction or follicle monitoring cycles. And accordingly, we can decide that what stimulation we have to give. Except in cases of PCOD, our aim is always to have a multifollicular growth of 2 to 3 follicles. So if the woman is young, then definitely either you use clomiphene or you use letrozole. It hardly matters. And they have got comparable results, whether you see it in the literature or in whatever we have been using it since now so many years. There is no difference in actually a pregnancy rates between the two things. We only have to see that whether the follicles are developing or not, endometrium is growing or not. So we can change the protocol. And if there is not multiple follicular growth is not there, then we directly start with 50 or 75 units of HMG or FSH, and depending upon again the age and the AMH and the previous response of the patient. So we start with low dose, and since we do a lot of IUIs and we do continue for 4 to 6 cycles, so we gradually increase. We have got leeway that if in 1 or 2 cycles she doesn't get ovulation good follicles, then we increase the dose even up to 150 units. If the patient is poor responder, we do IUIs even with 225. But if a patient of IUI is having to use 225, then we also tell her that your prognosis is not that good and she might have to go for IVF. And again, in that case also the ovary will remain same. So her ovarian response will not be very great. So we have to give the prognosis for future things also during the time of IUI itself.
Himanshu, your face is still fresh in my mind 20 years back when I saw you as a young man. No? Now you are mature.
I was also confused seeing you whether it is same Dr. Sarath or somebody different.
Yeah, thank you. Thank you very much for the elaborate answer. Yeah. So these are the drugs we use. Yeah.
For PCO patient also, if you have to prefer like letrozole, there's either no difference in clomiphene or letrozole as we already told. But for the PCO, we usually, PCO like now we call the PMO, so polyendocrinology metabolic syndrome. So we usually prefer, I think, letrozole. All guidelines suggest.
Thank you, ma'am. Thank you. Ma'am, these are the commonly used drugs for ovarian controlled ovarian hyperstimulation like clomiphene citrate, letrozole, and human menopausal gonadotropin are follicle stimulating hormone. Both urinary and recombinant preparations are available. Analogs can be given for ovulation induction or for down regulation, but when they are used for down regulation in IUI cycles, they'll become expensive, and most of the times we will time the ovulation for our convenience and for making ovulation doses of clomiphene citrate. Usually, we do a lot of IUA procedures in our clinic, and when when the woman is not responding to 100 milligrams of clomiphene citrate, instead of increasing the dosage, I usually add gonadotropin for further stimulation of the follicles. Then coming to the combination therapy. So when clomiphene citrate, the important prerequisite should be the hypothalamo-pituitary ovarian axis should be intact. And when we give progestogen challenge test, the progestogen challenge test, it should be positive, especially in case of polyendocrine ovarian syndrome patients. No, so the dose usually given will be 50 to 150 milligrams per day from third day to seventh day. When most of the times, HCG will be given as a ovulation induction agent, but sometimes when the follicle growth, clomiphene citrate induced follicle growth will be fine, but they fail to ovulate without HCG injections. No? So these patients, they'll be benefited by ovulatory injections of human chorionic gonadotropin. Then coming to the clomiphene citrate with estrogens. No? Sometimes we all know that clomiphene citrate is an anti-estrogen, and sometimes it may interfere with the cervical mucus production, and they may have a dry cervical, coitus or this one. Those patients, they may be, or for the case for the endometrial development also, if the endometrial thickness is not improving, some centers, they do add estrogens for further growth of the endometrium. But I don't have any first-hand information about it. No? And coming to the clomiphene citrate with the dexamethasone, when will we add dexamethasone? When the androgens are of adrenal origin, where the DHEA sulfate is high, probably a small dose of dexamethasone, like 0.5 milligrams per day, from day 1 to day 14 of the cycle can be added. Coming to metformin, if the woman is obese and with the polycystic ovarian syndrome, if she has abnormal glucose tolerance, she'll be benefited by adding metformin along with clomiphene citrate. Cabergoline. 25% of the patients with polycystic ovarian syndrome, they may have inappropriate hyperplatinemia, and these patients can be benefited by adding small dose of cabergolines. Then coming to clomiphene citrate with gonadotropins. Sometimes what happens, the clomiphene citrate induced follicle growth may not be sufficient enough for the further growth, for maturity of the follicles, and those patients will be benefited by adding gonadotropins in this particular scenario. Then coming to the basic procedure, as we already discussed about controlled ovarian stimulation. Second will be sperm preparation, and third will be insemination procedure. Yeah. Coming to the sperm preparation, prior to IUI, it is necessary to remove the seminal plasma to avoid prostaglandin-induced uterine contractions. That's the most important part. And insemination with unprocessed semen is also associated with pelvic infections. Then removal of the seminal plasma can be achieved by either relatively simple procedures like swim-up technique. Usually we'll use it for normosospermia, and the density gradient technique for oligoacintospermias, and microfluidics for oxidative stress.
So you have 15 minutes left. Perhaps you should let the panelists also speak.
Yeah, sure. Yeah, I'll be finishing this introduction, then we'll come to the questions. Yeah, insemination procedure, we all know about this one. Yeah, usually 0.2 to 0.4 ml of prepared sperms will be injected into the uterine cavity by various cannulas are available for that one, and we'll make the woman to lie down for about 10 to 15 minutes time, and then she can go back to her work. Then timing of the IUI. So usually, yeah, this is very important. Dr. Kunju Mohiddin, are you there?
Yeah, yes, sir.
Yeah, please tell me, how do you time your IUI?
See, basically the timing of IUI, first we have to time the trigger so that IUI can happen by around 36 hours, 34 to 36 hours. So that will be an ideal situation. And very often, if it happens to be on a weekend, you can even use antagonist and reschedule the cycle accordingly so that it will fall on a working day. And
But
by
I'm working in a rural center and I don't have an ultrasound. No? How do you guide that couple then?
see, if you don't have an ultrasound, you are not supposed to do IUI.
You don't depend on LA surge and other things?
No, nothing. Just ultrasound monitoring and doing IUI.
Is mandatory. Okay. Anyone differs with that one, or you all agree with that one?
So,
Madam?
one of my students given a paper also for which she got the best paper reward for the FOGSI conference also. So what we did that, like on Saturdays, if the patient comes on Friday and we have to do the IUI on Sunday we are closed. So we saw that we preponed either on Saturday or we postponed to Monday. And we saw that what was the result? Did it get affected negatively with this approach? And we found that it did not make any difference to the pregnancy rate. So you don't have to be too strict timing the IUI. It has been shown that 36 hours is the best. The paper supports that once insemination after 36 hours of HCG is good, but there is a lot of leeway around there. Lot means not 4-5 days or 3-4 days, but 1 day chalta hai. And again, during COVID times, if you remember that there was this protocol that when you see the patient, so you don't want her to come back after 2 days or 3 days. So you give HCG on the same day when the follicle is mature and do the IUI at the same time. And you will be surprised to know that we got the similar results even in cases when we did the IUI on the same day of doing the HCG trigger. So there is a lot of gray space, so we don't have to be too strict about it. And simultaneously, we don't have to be too lazy or too like this thing about it also.
Thank you.
Dr. Sarath, could I just add something? So,
please.
I completely 100% agree with both the previous panelists. Ultrasound is completely mandatory. We have to monitor any ovarian stimulation that we do, and that's the bottom line. But sometimes, so your question was, does anybody have any experience with the LH kit? So sometimes the patients like to be more involved with what's happening with their treatment. And I have patients that come up and say, ma'am, can I use an LH kit also so that it makes me feel as if I'm doing something for my own treatment? So I typically work in a metro, and we get patients who are very well read to do that. So at that point of time, I definitely tell them I will do the IUI. I will try and take a look at what's happening. But for the patient to know where she stands, generally I tell her the minute you see a surge, I will be doing the IUI about 12 to 24 hours after the surge. So this particularly helps my patients whose husbands are traveling or they have a very high pressure jobs. Then the husbands, of course, I'm giving an HCG, so I'm telling them 36 hours later. But then they have two things to discuss with their husbands about, okay, LH surge has happened, that injection is also coming. So, you need to be here at that time. So a lot of my patients do take a backup of the LH kit. And what I tell them is once you start getting the surge 24 hours later, I will have to do the IUI. But I will always and I'll always give an HCG.
Thank you. But evidence review, according to Human Reproduction Update 2018, IUI can be performed between 24 to 40 hours after HCG without compromising the pregnancy rates. Okay. Then coming to pre-ovulatory and ovulatory IUI. So ultrasound finding dormant follicle is about 18 to 20 millimeters, but not ruptured. No. These we'll interpret as a pre-ovulative follicle, and you can give HCG for this as a trigger, and we can go ahead with IUA 34 to 36 hours later. Then when follicle is ruptured, we'll with free fluid in the pelvis, then we'll take it as ovulation has already happened. Then we can do the IUA immediately. Then when LH surge is positive with a mature follicle, there may be imminent ovulation, and IUA usually next within 24 hours we can plan. Okay. Then single or double IUI, madam?
Single.
Dr. Riddhi is there. Tell me, Riddhi, what's your
single IUI. I don't have experience with double IUI.
Okay. Anyone differs?
Yes, sir. Dr. Shara, In case
Yeah,
if it is a male infertility, in that case,
oh,
I would like
oh,
to
yeah.
do the double IUI.
I
In the case
I
of
do
male infertility,
I do agree with you,
not
ma'am. I do
always.
agree with you. For male
Thank you
infertility,
so much.
probably WIA haven't role.
Yeah,
No? Yeah.
there's a
So
guidelines also, very reviews also. It is sometimes the results are better
So
in double IUI.
according to literature, single IUI per cycle is generally recommended, but WIA has insufficient evidence for better pregnancy rates. Okay. So coming to the factors affecting the success rates, Rajalakshmi.
So obviously, the indications will have a great bearing on the success or the failure. So obviously, older the patient, both the husband and wife, the success rate would be less. Patients with a poor total motile sperm count. So the total motile sperm count is classically divided into from grade 6 to grade 1. So if you have the lower counts of grade 1 or 2, then these patients would technically not do well with an IUI. Again, with the number of follicles, so mature follicles, when there are 2 or 3, they tend to have better success rate, as opposed to a single follicular growth. Again, the technique of the IUI, done as traumatically as possible with the patient comfortable. They've seen that the success rate is slightly better. So I have some friends of mine who would even use an ET catheter to do the IUI insemination because it's so atraumatic. And
I
but
do
then
agree
again,
with you, Doctor. Yeah. Usually, factors influencing the success includes age of the female partner, most important. Indication for IUI, that is also important. When you are doing it for idiopathic infertility, the chance of pregnancy are quite high. And the use of controlled ovarian hyperstimulation, when IUI is combined with the COH, the chances are better when compared to IUI with a natural cycle. And total motile sperm, as you already said, the total motile sperm count plays an important role in the success of IUI. Then, as I already said, the younger the age group, better with the chance of pregnancy. In patients with less than 24 years, they had a 37.5% pregnancy rate compared to the other age groups. Then, yeah, this is the graph where maximum number of IUI pregnancies happen within 3 cycles of IUI, and after that it will become a plateau. Okay? Yeah. Coming to the intrauterine insemination complications, Dr. Kunjumon.
So
So you
Dr.
have 5 minutes
Dr.
left.
Srishti has
Yeah.
also joined, sir.
Kanchan. Yeah. Now,
Sir, Dr.
yeah.
Srishti has also joined. You can take the opinion of Dr. Srishti Chaturvedi also.
Yes, yes.
Okay, Srishti is there.
The
Can I say,
complication.
Srishti, how are you?
Yeah.
We
Sir,
miss
I'm
you till
good. Good
now.
evening.
Now
Very
you
good
take.
evening, sir.
Now you
Amazing.
take this question. What are the
Yes, yes.
complications you come across during your practice?
So there is, sir, hyperstimulation happening in more than 2 follicles, 3 or more follicles maturing at the same time. If there is higher responders like PCO or with high AMH, so there are
Yeah,
chances of multiple
Srishti, what
pregnancy.
do you do in that particular scenario? What do you do to
So,
prevent
sir, I
pregnancy?
withhold the trigger and I counsel the patient that.
No. You should not do that one. I wanted you to go ahead with the GnRH analog, so you can give either
Okay.
leuprolide or this one.
Okay.
That way, even many follicles, so more than 5, 6 also, confidently you can
Yes.
go ahead and give this one, so that we don't have that fear of ovarian hyperstimulation syndrome.
Yes,
Then
sir.
what are
And
the other complications?
multiple pregnancy, higher
Yeah,
order triplets, and
yeah. That
higher
is
order
a
pregnancy.
expected
Yes.
complication. Yeah.
Yes.
Then what are the other
So it's a
complications you come?
infection can happen
Yeah.
if a pelvic infection and cramping, spotting can happen to the patients, and mostly these things
Actually,
are.
yeah. Infections are
Ectopic
quite rare with
pregnancy also.
IUI procedure. IUI is this, but as you said, vasovagal
Vasovagal.
that's very, very
Vasovagal,
important.
yes,
Yeah,
vasovagal.
because one patient I had where she became so this one, her BP has fallen, and I became so what can I say? I became anxious about that patient, and immediately we had to start the IV fluids and other resuscitate the patient. But in the same cycle, she has conceived. Happy to know about that one. Okay. So then conclusions will make it later. Coming to the case scenario, so Dr. Kanchan.
Sir, go ahead, sir.
Please go ahead. No, yeah. Now it's your turn. Yeah, please.
So I think your time is up. what we can do is we can invite opinions for everybody and also give the opportunity
So
to the
fast,
experts to
Pratik,
speak.
so fast. Did you
Yes,
reduce
sir,
your
you had a
time?
total of
Yes,
40 minutes, sir, unfortunately.
5 minutes. 5 minutes you give us. A few
but
There are
I
minutes.
think
800 people who are waiting for the
everything has been
post-test,
covered,
sir.
sir, in the
Yeah.
talk and panel, and you have led the panel very nicely, sir. So I think now
Thank
we
you.
can take the opinion of expert and all the panelists.
Yeah.
Arun Barua, sir is there,
Yes.
so we can take
Yeah.
this. Yes.
Yeah.
My opinion, everything was discussed thoroughly, but I have a reservation for the double IUI that already we had discussed. If we are at all doing a double IUI, what would be the reason number one? And if at all you are doing, what would be the time interval? Because doing an IUI, we must be optimizing our results. The evidence today doesn't support double IUI as far as I'm attached to this information. So I have a reservation and I accept everything that has been discussed in the platform other than the WIUI.
Dr. Barwa, actually, in the case of the male infertility, so there are a few papers, and they suggest the evidence is there. If we do at the interval of 24 hours, so by the time so the results are better in the case of male infertility. Otherwise, only single IUI should be done. And one thing also I would like to do in the case of the IUI, once we are doing, so there should be other factor like endometrium. Endometrium also be considered. It should be synchronized with the ovulation period. When
What
the
I do in
finding
my
of
practice
yeah,
is I try to actually
endometrium should be
calculate the Applebaum scoring, the
mm,
endometrial receptivity study, and if you combine it with
yeah,
IUI, your results get much better. That is
yeah.
doable in small places because with an ultrasound machine and a good study, you can always enhance your result at par with the textbook results that are available. So that would be my inputs to this particular platform, and I'm highly satisfied with the inclusion of this particular step in the IUI.
Yeah, and
So,
also it should be individualized, evidence-based to maximize the result of the pregnancy and preventing the OHHS and multiple pregnancy. That's my
Right.
input.
Dr. Me and Dr. Kanchan, we thank the panelists for their expert opinions, and we are so thankful to them for their time
Thank
and
you, Dr. Vatima. Thank you so much
thank
for
you,
the
thank you,
Thank you.
and
Thank you
Thank
so
you.
much.
I want to
and
thank
we
Pratik,
are
sir.
all we are all thankful to Dr. Pratik. No? Pratik is
Yes.
there sitting and looking at us. No? Thank you, Pratik. Thank you, and ICOG team, no, for giving this great opportunity. But we prepared so much, Dr. Pratik. We thought
I know,
we'll.
sir. In
So
fact, I had
sorry.
posted a message in the panel group yesterday that you have only about 40 minutes. So please pace yourself accordingly.
Yeah. Thank you.
So
Thank
thank
you
you,
so
everybody. Fantastic panel. Very good take-home messages. And thank you to our experts as well for sharing their valuable opinions. Dr. Monica, can I request you to please proceed with the post-test? Monica is busy with her doggy, so I think I will have to do the needful. Shreya, can you please post the test link
Yes, sir.
in the chat box as well as on the screen? We have 15 minutes for all the participants to attempt 20 questions, and at the end of those 15 minutes, we will have the answers being discussed by the coordinators for today. In the meantime, I would like to place on record my gratitude to all of our excellent faculty over the past 2 days. We've had some very engaging discussions. We've had some excellent coverage of male infertility and IUI today. And my gratitude to all the eminent speakers as well as the chairpersons who joined us today. This is a post-test link. It is being posted in the chat box as well as there is a QR code on the screen. My gratitude also to our two coordinators for today, Dr. Fasilui and Dr. Monica Singh, for doing the honors and taking care of the coordination minute by minute.
Thank you for the opportunity to ICOG, especially Dr. Pratik Tambe. It was a pleasure.
Not at all. Most welcome. Most welcome. So tomorrow we're going to have IVF, ICSI, and advanced ART. And traditionally, this is where the big guns all come out. and we discussed the practical relevance of advanced ART. So it promises to be another fruitful day with a lot of good evidence-based talks. Doing that post test on all 3 days is mandatory for you to be eligible for your certificate, and you need to score at least 50% marks. And I usually see to it that the MCQs are very easy this year. Yesterday's was like a walk in the park. I think a 5-year-old child would have done it. And today's MCQs are also relatively easy. It is customary for the audience once you finish to post a message in the chat box saying that you're done. So we have a rough indication of how many people have actually done the post test. Those of you who are in the audience and are not yet fellows of ICOG, thank you, Ipsita. You're always number one. You're the first to finish as usual. Those of you who are not fellows of the ICOG, the portal is open. The link is there on the website. I would request all of you to please apply. The last date is 15th of July, and the ICOG convocation will be held during the ICOG annual conference on 22nd of August in Bangalore. So I hope to see at least 200 of you receiving your fellowship at the ICOG convocation. The link has already been posted. It is being repeatedly posted. There is a QR code on the screen. You can scan the QR code. That will take you to the link. You have 10 minutes to finish 20 MCQs. Correct. This is the FICOG I'm talking about, Ipsita. Good. Deepika Verma is finished. Usha Goenka is finished. Shraddha Maheshwari is done. Very good. Shabnam Naz is also done. Very good. There are people who have finished 20 MCQs in 5 minutes. That means they're an expert. Dr. Jaya has also done. Very good. Sukirti is also here. Sukirti, you don't need to be here for this certificate. You already know more than most of us. Dr. Lavanya, Navina, Jyoti Khatri, Rajalakshmi, Ruchi, Archita Chawla, Spurti Prakash, Janak Patel, Harshita Hari, Saraswati. I'm seeing a lot of new names, so I'm happy that more and more people are coming onto the ICOG platform and becoming part of our family. Kirti Agarwal, Vishi Rawat, Praveena, Nayaka Kaveri, Sujata Shisode, Shreya Mattu, P. Rohini, Priyanshi Thakur, Babita Sikriwal. A lot of new names I'm seeing. That's good. I hope all of you are enjoying the course. And in case you have any feedback, feel free to write to us or post a message to us directly. Manisha Chauhan, Pooja Singh, Nandini Kapoor, Sujan Bhusal, Lakshmi Priya, Aisha Siddiqui, Swati Deshpande. So today, despite it being a bank holiday and probably family time for most people, Mohini Abreu is also very nice. Nitya Nagaswamy. We've had audience. Yesterday we had 950 plus. Today we still are maintaining 800 plus, so that's excellent. Dr. Ruchi says it's a good and informative platform. In one place you get it all. Yes, thank you. I think that speaks volumes for all the hard work put in by all the coordinators on all 3 days. Didn't submit yesterday's MCQ, no certificate for you then. Apologies. Nisha Chauhan, Arpita Alpana Varshini. Charu Mittal is here. Hi, Dr. Charu. Nice to see you. Pranati Rai is one of our fellows only, I'm not mistaken. Namrastogi, Sajita Kumari, Vartika Kishore, Vitra Arun, Pragya Mishra. There must be more than one Pragya Mishra. I know one in Patna. Bharti Ray, Jagriti Nagar, Hampton. Preet Ruby, Mansi Atreja. Ritu Jain, Dirashik Kumar. Now the names are really coming in fast. You're not going to be able to receive each day's score because the Google form does not have that facility. What happens is at the end of 3 days, then we collate all the data together. It is processed by the backend team. And those people who have attained at least 50% marks on all 3 days receive the certificate of attendance. Thank you, Dr. Charu, for those kind words. About 5.5 minutes to go, so you'll have to bear with us until the full 15 minutes are up, and then we'll discuss the answers. And don't fret, this year we've introduced something different for those people who don't finish 50% of the post-test. Still, if you've attended 2.5 hours on each of the 3 days, you still get a certificate of attendance. It might not be the credit point certificate, but you still do get a certificate. But you have to attend 2.5 hours at least on each of the 3 days. And this is something which Dr. Sheila Mane and myself have introduced only this year. Previously, we didn't have this. Thank you, Ipsita, for those kind comments. When you have higher viscosity and higher liquefaction time, you ask the male partner to ejaculate directly into a container which already contains some medium. That is the recommended methodology of collection. If you miss the first test, then you will not be able to do the test again because the answers have already been discussed yesterday. Thank you, Dr. Vindashri, for your comments. Recorded lectures, you will get these lectures of the 3 days posted on the website. And this is usually done after about a week. Received only one certificate because you must not have got 50%. or you are not present properly. There must be some mismatch in your email address or the details that which you have submitted. If you've attended only for 2 hours, then you better get more than 50%. That's the only way you'll get a certificate. Thank you, Dr. Bhargavi. Thank you, Dr. Shekhar Sachan as well. Dr. Kesharda, how are you? I'm in Delhi right now. I will be visiting Faridabad soon. You will not get an individual notification after every test, like I just explained. You will get the email with the certificate directly after the backend is done all the processing. So that typically takes about a week or so. Viscous sample is directly to be ejaculated into the sperm wash media, which is there in the container given to the male partner for collection. Double IUI statistically does not yield better clinical pregnancy rate. If you want to go ahead and do it, you can do it after 12 or 24 hours. Yes, that's fine. You can do it at 12 hours and 36 hours, or you can do it 24 hours and 48 hours. It doesn't make any difference. Yes, Dr. Mansi, please type your question in the chat box. Yesterday missed, unfortunately, nothing can be done because you already discussed those answers. If you missed yesterday's lecture, then yes, it will be uploaded on the website after a week or so. You will not receive the email on each day. You will receive the email directly after the backend team has done all the processing. Thank you, Dr. Komal. That's a very nice comment. Thank you, Dr. Rekha Rani. Certificate of pass is being processed, Dr. Irfana, and you will receive it very soon by email. If you've missed yesterday's lectures, you will have to view the recordings, which will be uploaded to the website after a week. For the registration, you will get an email. Everybody who registers gets an email. It's fine if you don't message in the chat box that you've submitted it. That's perfectly all right. Excuse me. We have recorded sessions of the previous year as well. They are there in the archive. We have a certificate course in the 4th week of every month, Tuesday, Wednesday, and Thursday. It's a 3-day course every month throughout the rest of the year on different topics, obviously. Patient has maturation arrest at secondary oogonia state. You will need to have a good counseling from a genetic counselor and a urologist or an andrologist. Typically, these patients will require ICOG, and even with that, the prognosis is a little poor. You can end up doing IUID in these patients. So that's the end of our timer for submitting the MCQs. Can I request Shreya from the backend team to please share the PDF with the answers, and I will request Dr. Fesi Loy and Dr. Monica Singh to give out the answers, please. Shreya? Ipsita, we were to have the surgical demonstrations by Dr. Sunil Jindal. Unfortunately, he was held up and he couldn't deliver his talk. So Dr. Fesi and Dr. Monica, maybe you can do 10 each. Please unmute yourself and only give out the correct answer. Need not read all the options. I'm sending both of you an unmute request.
Okay. Pardon? Okay, I was in a mute form.
You can do the first answer and Monica can do the next 10.
Okay. So the first question is, a 29-year-old woman with unexplained infertility is planned for IUI with ovulation reduction. Which of the following agents is currently considered the first line of ovulation reduction in women with PCOS undergoing IUI? Letrozole. I think all would have got the answer. Second, during control ovarian stimulation for IUI, which follicular response is generally considered optimal to balance pregnancy rate and the risk of multiple pregnancy? 1 to 2 mature follicles of 18 to 20 millimeters. And in an IUI cycle using gonadotropins, which of the following is the most appropriate indication for cycle cancellation? More than 3 mature follicles in women with less than 35 years. 1 follicle, endometrial thickness 8 millimeters, serum estradiol, all are good indicators. Okay. Then, according to an American Urological Association or ASRM guideline, which should include in the initial evaluation of male infertility, which should be included: reproductive history and semen analysis. Hormonal profile, as I told now in my talk, it is not routinely indicated. Genetic test also is not indicated for all, and testicular biopsy only for a few, as told in the talk. How many semen analyses are ideally recommended when evaluating male infertility? 2 analysis at least 4 to 6 weeks, that is 1 month apart. Which therapy should not be prescribed to men desiring current or future fertility? Exogenous testosterone, because it will negatively inhibit the spermatogenesis. Then, which hormonal treatment is considered the first line therapy in hypogonadotropic hypogonadism? That is, he is considered the first line is HCG to prime the cells to produce the testosterone hormone. Then, which of the following lifestyle factors suppresses spermatogenesis during use? Anabolic steroids suppress the sperm. That is, suppression is because of the anabolic steroid in that. A patient with azoospermia has normal testicular volume, normal FSH, and palpable vas difference. Which genetic abnormality is most likely? CF60 fibrosis, trans receptor gene mutation. That is most and palpable vas difference, most likely. Okay, then last question, 10th question is that in non-obstructive azoospermia, microticide sperm retrieval success rate correlate most significantly with larger testicular volume. The others, it is the most appropriate answer. Monica, Dr. Monica?
Yes, sir.
Number 11 onwards.
Yes, sir. For ideal sperm capacitation, what should be the temperature of sperm preparation media? The correct answer is 37 degrees Celsius. Question number 12. HEPI's media mostly used for sperm preparation should be put in plain incubator at 37 degrees Celsius. That's the correct answer. Question number 13. What does an ideal sperm wash achieve? It achieves all of the above: harvests best quality sperm, enhances capacitation, and enhances activation and kinetics. Question number 14. Which of the statements is correct? Out of these 4, swim-up method for normospermic sperm sample and density gradient for oat sample. This is the correct statement. Question number 15. Subjecting the sperm to excessive centrifugal force in excess of 300 G can lead to increased oxidative stress as well as increased generation of ROS. Which of the following describes IUI? Question number 16. Injecting washed sperm into the uterine cavity is best definition of IUI. Which patient factor is a good indication for IUI? Unexplained infertility or mild male factor infertility are classical indications for IUI. Which procedure improves IUI success rate? Ovarian stimulation with gonadotropins, semen washing, luteal phase support, all of the above. Optimal timing for IUI is around the time of ovulation. What are the commonly reported success rates with IUI? 10 to 15%.
So thank you very much to our course coordinators for today, Dr. Monica Singh, Dr. Faisal. Thank you to all of our excellent faculty, our speakers, chairpersons, moderators, experts, and panelists for imparting your knowledge and sharing your valuable clinical expertise. There are just a few couple of messages that I need to convey on behalf of Dr. Sheila Mane. The ICOG annual conference is on 21st, 22nd, and 23rd of August in Bangalore. The ICOG convocation will be held on Saturday evening post lunch on 22nd of August. Those of you who are eligible, please apply for the fellowship and you can receive your FICOG during the convocation. And as always, I would like to thank our backend team, Nilima, Poonam, and Shreya, for all the hard work and efforts. There have been some complaints that people were not able to submit their test results, even though the timer was not yet up. I would request the backend team to please look into this. And we will see all of you tomorrow at 4 o'clock for the final day's proceedings when we discuss IVF, ICSI, and advanced ART. The coordinators for that day are going to be Dr. Ritu Khanna. And thank you, Dr. Ritu, for being here, even otherwise, on all the 3 days. So until next time, goodbye, God bless. Thank you, everybody. Thank you, Dr. Kanchan. Very nice panel. Very beautifully crafted.
Dr. Pratik,
Thank you so much.
so much for giving the opportunity. Thank you so much.
Thank you, Pratik, for this wonderfully, planning and implementing this thing course. I think
Thank you,
hats
sir.
off to you.
Thank you,
very
Dr.
much.
Very meticulous work